certificate course on a very good afternoon to all the respected seniors and delegates who have joined today for this FOGSI ICOG online certificate course on labor and birthing. The course has been spanned over 3 days. Today is the second day. Yesterday was a very successful first day of the certification course, which is run in the vision of Chairperson of ICOG, Dr. Parag Binimale sir, and Secretary Dr. Sarita Bhalerao madam. With apt support from FOGSI President, respected Dr. Sunita Kandulwadkar madam, and Secretary Dr. Suvarna Khadilkar madam. The course coordinator for this certification course is respected Dr. Sharmila Ayabu madam, and today's chief guest for second day are Dr. Ashok Kumar sir, Dr. Sadhana Gupta madam, and Dr. Sheila Mane madam. So I would like to welcome Dr. Parag Binimale sir to kindly say a few words.
Yeah, thank you, Rashmi. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all on the second day of 3-day certificate course on labor and birthing, which is the brainchild of our dear governing council member, Dr. Charmila, of course, ably assisted by Dr. Rashmi Kahar, who's the chairperson of Practical Obstetrics Committee of FOGSI, and Dr. Poonam Goyal, who's a governing council member and chairperson of Safe Motherhood Committee. Yesterday was an interesting day where there were good discussions in the panel. Of course, there were some nice video presentations also by some of the faculty. I hope everybody liked yesterday's presentations. So here we are on the second day, and we are looking forward to yet another exciting day with a lot of newer insights into management of labor and birthing. My best wishes to the program and special appreciation to all my 3 conveners who've shouldered the responsibility of conducting this course. Thank you.
Thank you very much, sir. We would like to hear from Dr. Shamila madam.
Reshmi, you can continue. It's okay. We'd like to welcome all of you to this program. As Dr. Parag said, it has been a very great day yesterday, and we hope that it will be the same today. Anybody who wants to have some interaction with speakers, please stay back after the program, because the post-test assessment has to be on time, and after that we'll have the interaction. And we request that the speakers and chairperson stick to time, because we need to finish as per the schedule, because otherwise it will be difficult to hold the assessment. I think Dr. Girija has joined. So Reshmi, we can start the academic session.
And just a quick mention for all the speakers, the delegates will post questions in the chat box. So after your presentation, please answer all those queries so that whatever issues the delegates want to be clarified, they will be benefited. Thank you. Over to you, Raj.
Please make Dr. Girija as a co-host tech support, please. Please unmute.
Hi, good afternoon.
Hi, Girija.
Good afternoon.
Okay. Reshmi, you can invite the chairpersons and we'll start. Kavita is there.
Thank you so much, madam. The chief guests for today's session are Dr. Sadhana Gupta, madam, Dr. Ashok Kumar, sir, and Dr. Sheila Mane, madam. We would like to have a word from them if they are present, or when they join, we will hear from them. I would also like to acknowledge the work done by the coordinators of this session, Dr. Umail, Dr. Kavita Bhatti, madam, and Dr. Monica Umbertan. So without much ado, let us start our scientific session. The session first, and the chairpersons for this session are Dr. Shobha Gudi, madam. And I would like to introduce Dr. Shobha Gudi, madam. She is professor and HOD of St. Philomena's Hospital, Bangalore, and she is a postgraduate teacher and examiner. We know her by her work of Family Welfare Committee of FOGSI. Our next chairperson for the first session is Professor Dr. Bharti Maheshwari. She's professor and HOD of Department of OBGYN at Muzaffarnagar Medical College, and she has been chairperson of FOGSI's MTP committee in 2018 and 2020. We welcome both the chairpersons, and we would like to introduce Dr. Girija Wagh, madam, to the house. Dr. Girija Wagh, madam, as we all know, she's a great academician, professor, Department of OBGYN, Dr. Bharti Vidyapit Medical College, Pune. She's a senior consultant, Cloud9 and Apollo Hospitals at Pune. And we have seen her huge phenomenal work as a Vice President of FOGSI last year. Welcome, Madam, and we would like to hear from you.
I don't know, I'm unmuting, but still it is saying.
Dr. Girija, Madam, she will be talking on interventions in labor dystocia.
Okay, can you see my presentation?
Yes, Girija,
Yes, ma'am.
seen.
And I'm audible?
Yeah,
Yes.
very much so.
Okay, thank you so much. So in the next about 15 to 20 minutes, we are going to speak about interventions in labor dystocia. And as I have been instructed by Dr. Chamila, we'll try to, be swift in whatever we have to understand. Thank you for that very kind introduction. And what we are going to learn in this 15 to 20 minutes is to be able to identify dystocia, to find out the ways in which you can, diagnose it, and then the challenges that are there. So we all know labor dystocia refers to a slow progress during labor and is a common reason for unplanned cesarean births, and that's something that really irks us the most. And usually then we realize that probably we have given trial to the patient, and then we landed up getting into a very difficult second stage labor, and probably things were already there stalking at you. So it's very important that we are able to avoid an unplanned C-section, because today we know as unplanned C-sections are similar in their morbidity as would be a difficult vaginal birth. So scientifically, if you look at labor dystocia, it's also referred to as difficult or obstetric labor, which encompasses a range of complications during childbirth. And these are typically as slow cervical dilatation, fetal descent challenges, and shoulder dystocia. Now, we all are aware of the 3 Ps of labor, like the power, where there has to be proper myometrial contraction, passage, the soft tissue, as well as the maternal bony pelvis, and the passenger, how the fetus presents and accommodates to the passage is very, very important. And when we look at 3 Ps of the labor dystocia, they are the complications that would be categorized typically as the 3 Ps as power, where there'll be abnormal uterine contractions. It may be hypotonic, where there can be insufficient pressure during contractions, hypotonic, where there can be elevated basal tonus or poor coordination. There can be passage-wise cephalopelvic disproportion, pelvic bone or soft tissue abnormalities, and passenger, there can be factors related to the fetus such as malposition, presentation, macrosomia, congenital malformations. And of course, the 4th P is very important, and this is something that we are very commonly facing today, is the mother's psychological state, which can impact labor progression. So to diagnose labor dystocia, primary dystocia typically would be slow progress of labor less than 1 centimeter per hour. And secondary would be no progress for more than 2 hours after initial normal progress, and more frequently seen in nulliparous women. And it is increased risk in parous women without previous vaginal births. And there are certain risk factors for labor dystocia, and these would be maternal factors such as obesity. Slow labor progression in overweight and obese women have been absolutely seen, and this would be typically seen because of the prolonged latent phase of the first stage of labor. There can be other associated conditions such as PROM, because a very supportive bag of membranes is now not there to help cervical dilatation. Polyhydramnios, because there can be sudden, like recently I experienced a patient suddenly changing her presentation. Gestational diabetes, hypertension can also be there. Psychological, we've already discussed, and there can be fear of childbirth, which can increase labor duration many a times in patients. So whenever we're looking at the disorders of fetal descent, we have to look at this very wonderful diagram, I feel, which I got from one of the publications in 2024, is the curve of the fetal descent versus elapsed time in labor has a latent phase like the curve of dilatation. So you can see here in nulliparous, there is little or no progress in descent until the phase of maximum slope of dilatation occurs. And the descent accelerates and becomes linear by the descendant phase and dilatation of the second stage of labor. And active descent proceeds at a constant rate until the fetal head encounters the pelvic floor, and descent when slows as the head extends under the pubic symphysis and delivers across the perineum. So you can see here that this is the normal descent that you would be experiencing. And protracted labor and protracted descents would be typically seen in E. Nothing would go absolutely move around. There can be arrest of descent, as you can see here in this D graph. And you can see that this is a protracted descent as has been seen in C. And here it is a completely failure of descent. And this is an article which I would want all the people to read. It's a very wonderful article, Cohen's Second Stage of Labor, American Journal of Gynecology 2024, which will give you a wonderful insights on how labor has changed over a period of time. Now, the presenting part would be many times very, very high, and some descent may be observed in the latent phase of dilatation, particularly in the multiparas. Fetal head passively accommodating to the thinning and the lower segment, and we feel that, oh, maybe the descent is occurring. And this would be quite normal for little or no descent to have occurred until nearly full cervical dilatation has been reached. And therefore, many times, judgments about prognosis of vaginal birth cannot be made based solely on a lack of descent before the deceleration phase of dilatation. So again, coming back to this particular diagram, you can see the failure of descent. And this can be highly because of cephalopelvic disproportion. And the wrong judgment would be by giving oxytocin. But normally, many times we feel that maybe the myometrial contraction is not adequate. And therefore, we tend to give oxytocin. And sometimes that would not really help. And in a protracted descent, as you can see here in the graph here, having entered the active portion of the descent curve, progress continues linearly at a rate slower than the accepted limits of normal, which we know in a nullipara is 170 per hour and 2 centimeter per hour in a multipara. And then cessation of progress over 1 hour after the active phase of descent has commenced is typically called as the arrest of descent. Now, there are common follies which can happen, and these are too often not recognized, diagnosed incorrectly, leading to the potential and unnecessary and delayed interventions. So, how do we interpret whatever we see in labor? Now, if you have an unengaged head in a nulliparia, risk factor for CPD has to be kept in the mind, especially at the brim of fetal malposition. Large fetal weight can be there. It can be a fetopelvic disproportion, which can be again a risk factor of CPD. Not only that, dysfunctional labor pattern and shoulder dystocia. And remember, diabetic mothers who have very high insulin resistance also have very, resistant sensitization to the oxytocin, and therefore they'll have prolonged labor many times. Fetal malposition may preclude further safe labor, and it can be a risk factor for CPD or signal non-gynecoid pelvic architecture. Long, steeply inclined symphysis pubis, suspect android pelvis and anticipate possible shoulder dystocia. If you have very thick sacrospinous ligaments, possible narrow mid-pelvis posteriorly, sacral curve may be shallow, posterior space may be insufficient. Sacrospinous ligaments are long, then suspect anthropoid pelvis with posteriorly recessed sacrum or suspected flat pelvis with widely separated side walls. Diagonal conjugate is short, suspect flat or generally contracted pelvis, consider inlet disproportion. And AP dimension of outlet is short, may deliver occiput transfers. Anterior shoulder may not stem beneath symphysis pubis, causing shoulder dystocia. So a proper pelvic assessment when the labor has started is extremely important, because by now the ligaments have become adequately lax. The baby's growth has now completed. And this is the point in time where you should do a proper assessment of the cephalopelvic disproportion. Now, if you look at the dysfunctional descent patterns and definition and significance, prolonged deceleration phase would be where deceleration phase exceeds 2 hours. And here recommended management is oxytocin only if there is no CPD, and cesarean delivery if other risk factors for shoulder dystocia exist. And the significance is it's associated with CPD, shoulder dystocia, malpositions, excessive sedation or analgesia. Protracted descent, we have already seen. Observation or support unless caused by inhibitory factors. Cesarean delivery if CPD is probable, associated with CPD typically. Arrest of descent, maybe if there is no CPD, you can give oxytocin. Cesarean delivery if CPD is probable. Failure of descent again. So every place you will have to do a proper pelvic assessment to rule out cephalopelvic disproportion or any kind of pelvic abnormality. And if there is precipitate descent, usually too late to treat when diagnosed, in time allows, uterine contractions may be inhibited with tocolytic if necessary and associated with shoulder dystocia, fetal and pelvic floor injuries. Now, there are some lamentable trends which are set in meantime while we have been looking at how best, because we know that deliveries don't occur always with an obstetrician who's an expert, and there are so many others who have to deliver. And therefore, there are some recommendations for the treatment of dystocia, emphasize the liberal use of oxytocin, which may not always be safe. Disregard the evaluation of pelvic characteristics, again, very wrong. And this denies the obstetrical attendant the satisfaction that comes with an understanding of the beauty and the logic of mechanism of labor. Ill-considered use of uterotonic agents or neglect of labor abnormalities may be harmful to both the mother and the fetus, and consequently even to the obstetrician. So this is something that we have to be remembering. So just a quick recce on why this particular, again, the same resource, you can see this is another one online published on 19 of October 2020, which has done again a practical review of the technique which refers to the Cohen et al, which is done, where you have to carefully look at the maternal features, the fetal features, and it's very important to assess the pelvic passage as well as the passenger absolutely thoroughly. And I would recommend that everybody here in the class today reads both these publications. So the mechanism of labor is influenced by many factors, as we understand: fetal size, its ability to mold, distensibility of the pelvic joints, uterine contractility, pelvic soft tissue factors, degree of the flexion of the fetal head, and the fetal axis. And therefore, there's very one important maneuver which we have been taught as we were postgraduates, and this is something that we have to again remember. And this is the Mueller-Hillis maneuver for dystocia, which involves, as you can see in the picture, determining changes in the position and the station of the head by a vaginal examination, while steady, gentle fundal pressure is applied. And some find it helpful adjunct to standard clinical cephalopelvimetry in predicting further descent and rotation when applied during second stage of labor contractions. Now, this has, however, as you can see here, that limiting its use to the second stage of labor during a contraction naturally. The maneuver was performed by one examiner, and this was a study which has also been done on this. Descent of 1 centimeter or more was deemed a positive maneuver. Descent of less than 1 centimeter was deemed a negative maneuver, and the labor outcomes were analyzed according to the results of the maneuver. And a positive modified Mueller-Hillis maneuver in second stage labor had a high predictive value for vaginal birth. A negative maneuver was significantly associated with high operative births, prolonged second stage, and abnormal position. And these results indicate that this modification of the Mueller-Hillis maneuver needs to be considered for its utility in second stage of labor. And you can see that this is a 1996 publication, which still holds true when we do not have access to intrapartum ultrasound. Now, today, with the advent of ultrasound, this can be used as a very useful tool to help in the determination of the prognosis of vaginal birth. And this is the assessment can be made translabially or transperineally, as you can see in the picture, somewhat less invasive than vaginal examination, and likely to be, as is my time up?
No, you've got 2 more minutes, Girija.
Okay,
It's 12
likely to
minutes.
be more accurate than digital estimation. The angle formed between the symphysis pubis and the fetal head seems to have value in predicting vaginal birth, as equivalent or superior to skillful manual examination, and reintroduction of these fundamental skills is therefore essential. And then second stage assessment, duration, dilatation, descent, looking at the timelines correctly, whether you have used the epidural analgesia, what is the time of labor, following the partogram correctly. If you're using the WHO, the labor care guide, fine, but continue using these correctly. And therefore, studying the duration is very important, because poor outcomes were largely confined to labors that had a demonstrable graphic abnormality, such as failure, protraction, arrest of descent, and anything that's longer than 3 hours can definitely affect the neonatal condition. And this is something that has to be graphically documented. And especially remember there's something called as a vaginal phase in a primipara, because these can be associated if there is a prolonged second stage of labor, there is an increased soft tissue injury in the form of anal sphincter injury, episiotomy, and postpartum hemorrhage. And these have to be looked into, because soft tissue, you have to give them some time till it molds and gets ready. Now, this is an algorithm. I'll not go into the detail what you have to do in the second stage of labor, because we don't have time. But this is something which I can paste in the chat box, copied from here, and you can all study and follow in the event of how and when you manage your patients. Fetal heart patterns are also important because attainment of full dilatation is often heralded by the appearance of decelerations. And if it is very, very low, then that is trailing us that there's some damage happening to the baby and we will have to take quick decisions. And there are several factors which predispose to heart rate patterns, which have to also be remembered, such as cord entrampment, ruptured membranes, then the fetal abnormal pressure on the fetal heart. And in addition to this, there can be mechanical factors such as the uterine blood flow, increasing uterine artery, and intense maternal bearing down effects. So NST or CTG can be properly associated. We are not very well versed with fetal scalp assessments. It's always better to improvise on the positions of labor. We had a wonderful lecture yesterday, and you can understand that this can help women. It's very important to encourage them to have proper type of breathing techniques. There shouldn't be a spontaneous pushing technique includes breathing with open glottis, and that the number of pushing efforts and the duration are determined by the urges of the woman's body. And there shouldn't be, a suppression and a Valsalva type of a breathing, which is by holding the breath, because closed glottis pushing will cause more problems, while open glottis pushing will give better placental perfusion and better possibility of a woman delivering. And effects of pushing technique have been studied in a randomized control trial, and it has been shown that open glottis pushing is a better idea. It's very important to have judicious timing, type, and repair. Always when you have done a difficult delivery, do a PR before you suture the episiotomy, otherwise you have missed an OSE, and this is something that one has to remember. Always use pain relief very liberally. It can be in the form of an epidural or a tramadol or an anafortan. And that
sorry to interrupt the time.
and then you can also consider using MRIs in certain situations. Some of them have done these studies. It's not something which is very easily accessible, but you can consider in patients who are having fetopetal dysfunction to tell them what would basically suit them. So thank you so much. And I hope I have been able to cover whatever was given to me. There is never ending talk which I can give on labor dystocia, and there's so many things to learn. However, I hope I have been able to make some justice. Thank you.
As always, very, very precise, wonderful talk. And we are collecting feedback, and probably we'll call you back for a masterclass soon. Wonderful talk. Thank you so much.
Thank you, my dear.
Yeah. Can you make Dr. Shobha Goody as co-host? She's one of the chairpersons.
I'm supposed to do that?
No, no. We're telling the tech support. Reshmi, you can introduce a second speaker by the time Shobha Madam joins.
Okay, our heartiest welcome to Dr. Shobha Goody, Madam. She is the chairperson of this session. Madam is a HOD professor at St. Philomena's Hospital, Bangalore. And she has been chairperson of Family Welfare Committee of FOGSI, and we have seen her tremendous work in this area. Welcome, Dr. Shobha Goody, Madam.
Madam, please introduce the second speaker. Reshmi, can you flash Dr. Anupama's CV, please? Oh, Kavita can do. Kavita Bhatti is there. Kavita?
Yeah,
one of you should share the CV so that she can introduce.
Yeah, it will be a pleasure to introduce a very dear friend, Anupama, who also happens to be from my city of residence. Okay. I have known Anupama to be a very assiduous academician for many years now. And she has had a good stint of clinical work before she decided that it was public health which was her passion. And right now she is technical lead for maternal, newborn and child health and women's cancer projects. She's the senior technical advisor, Women's Health, Japaigo, India. She's an executive member of FOGSI Safe Motherhood Committee 24 to 26 and member of National Mentoring Team for Lakshya Labor Room Quality Improvement. That is such a wonderful post you are holding, Anupama. And then
you can start the
Maternal
talk,
Death
madam.
Surveillance and Response Committee as well. I'm here. I'm here.
Yes,
yeah.
ma'am. Yes, ma'am.
So
You can start the talk,
invite,
madam. Yeah,
yes,
ma'am.
I invite Anupama to deliberate. Yes.
thank you. I'll just share my presentation. Just let me know if y'all can see it.
It's visible, Anu. It's seen.
Okay, all right.
You have to make it a slideshow.
Yeah, I'll do that. Okay, so thank you, ICOG, Dr. Parag. Thank you, Dr. Charmila, for this opportunity. And it's a pleasure to be a part of this prestigious course. And my topic today is on intrapartum ultrasonography. And I think Dr. Girija's talk set a very good background and context for my talk. So we know that ultrasound has a huge role in antenatal care, but now more and more importance is now being given, and people have been talking about how intrapartum ultrasound can help in better labor management. So in our busy labor rooms, when we monitor traditionally with a digital vaginal examination, we are faced with multiple questions. Will an induction of labor fail? Will a ventouse application work? Or should we do a cesarean? If there's a large caput, where is the station? Or if the second stage is prolonged, is it due to an occipital-posterior position? Or, of course, obvious things like if I can't hear the fetal heart sound, I want to reconfirm with an ultrasound if it's an IUFT, and if previously antenatally scan is not done, is she bleeding because of a low-lying placenta, and post-delivery if there are retained products which are causing PPH. So all these questions all of us face during our day-to-day practice, and let us see if ultrasound can be an answer to some of these. And in recent times, in 2018, the International Society for Ultrasound in Obstetrics and Gynecology, one of the largest bodies, has come out with guidelines for practice guidelines for intrapartum ultrasound. And most of my talk is based on what are the now recent guidelines for doing an ultrasound during the intrapartum period. So again, the disclaimer is it is not supposed to, replace a clinical examination, but it will only be an adjunct to our practice in the labor rooms. You can do either a transabdominal or a transperineal, as Dr. Girija briefly alluded to the transperineal ultrasound. The non-negotiable and obvious reasons in an emergency situation are, of course, if there's a tetanic uterine contraction, you want to find out if there's a placental abruption, you can do an ultrasound. If there's clinical suspicion of rupture uterus, you want to confirm it, you can do an ultrasound. And of course, as I said, low-lying placenta, placenta accreta, all of these are, indisputable emergency situations where you might want to do an ultrasound. But what about labor induction? So suppose you want to, Bishop's score has been there since 1964, and all of us are used to assessing the favorability of the cervix using a Bishop's score. But the problem with the Bishop's score is it is very subjective, and there are very high inter and intra-observer errors that happen. And hence, recent papers say that there are two measurements that are used now and can be very successfully used for predicting the induction of labor outcome. And these two measurements is what I'll talk about. One is the cervical length, and the second is the posterior cervical angle. And these are supposed to be superior to the Bishop's score. And if there's an objective way where I can tell you that this induction is going to work, what better situation we can be, rather than worrying whether, and most often we know sometimes the Bishop's score does not finally mount up to a successful induction. So what are the two measurements that we can do? One is a cervical length. This is done transperineally, where simultaneously we image both the external and the internal os and measure the distance. And this distance, if it's less than 2 centimeters, then it is supposed to indicate that there is a favorable outcome. The second measurement that we can do is called posterior cervical angle. Now, this is also the length of the cervix and the angle between a tangential line drawn at the posterior wall of the uterus. So if this angle, what is called the posterior cervical angle, if this is more than 110 to 120 degrees, then the chances are that this induction will succeed. So these are two objective measurements that we can use in our practice for knowing whether an induction will succeed or not. Then let's look at like as Dr. Girija spoke about dystocia, let's look at, dystocias both in the first and second stage, where ultrasound can be used as an adjunct to clinical evaluation. There are enough papers, and Dr. Girija also alluded to that clinical examination is usually inaccurate and subjective, especially if you want to know the head position and head station, especially in cases where there's a huge, large caput and there is molding. So the error ranges between anywhere between 30 to 70% when we are, clinically evaluating. So there are now several studies which have demonstrated that ultrasound examination can be accurate and reproducible for diagnosing both the head position and the station. So let's look at what are the things that we can measure to know whether the head position and the station are, something that will make a difference in our decision making. So if we look at a trans-abdominal scan, we can do that to find out. Usually the probe is placed just above the symphysis pubis. And you can see that in an occipito-anterior position, you can see the cervical, the spine and the occiput. So this will clearly indicate that this is an occipito-anterior position. Whereas if you put a probe just above the pubic symphysis, and if it's an occipito-posterior position, you will image both the fetal orbits. And this is very easy, and it's a very it's a very easy way to diagnose so that you can make correct decisions and early decisions. Then the second one is, if you want to find out what is the descent of the fetal head. So what is the station at which, most often when we do a pervaginal examination, the large caput, it's really very difficult to know where the head is actually, the station, which is, the level at which it is in the pelvis. So we can measure something called a angle of progression. It is also called an angle of descent. Here, it's an angle between the long axis of the pubic bone and the lowest part of the fetal skull, deepest part of the fetal skull. So this also provides a reasonable assessment of the head descent. So if it's at station 0, the angle of progression is supposed to be 116. So the moment the baby is coming down, further down, you can look here, the moment it comes down, the angle keeps on increasing. So the higher the angle, the more favorable the descent is, and you can also clearly say that this is likely to deliver without any problem. So the angle of progression or the angle of descent is used to find out what is the station, where it's difficult clinically for us to know what is the station. Then the third one is the pubic head symphysis distance. This is the distance between the pubic symphysis and the fetal skull. So the moment the baby comes down, this distance becomes shorter and shorter, and that also again indicates that the head is descending towards the pelvic floor. So these are the two measurements that can be used for knowing the station of the baby's head. Then what about flexion and deflection? Again, we know that if it's a deflexed head, the chances are that it likely to go into arrest the labor. So this is again very logical. So you just measure the angle between, for an occipito-anterior position, you measure the angle between the cervical length and the second line drawn tangential to the occiput. This is the angle, and this determines whether the baby's head is flexed or deflexed. So we can see in the next picture. So if it is a wide angle, then it's likely to be that the head is going towards a flexion. Whereas if it's a very narrow angle, we know that it is probably going to be a deflexed head. So these are the two things that we can measure. And suppose what if it's an occipito-posterior? Then there's something called a chin to chest angle, flexion, deflection. So here we measure the long axis of the sternum and the chin and the oral cavity, a line drawn here. So this again, if it is, if it is flexed head, then this angle is going to be very narrow. But if it's a, if it's a deflexed head, we know that this angle is going to be very broad. So these are the few of the findings that we can measure on ultrasound to know when we are totally at a loss, where clinical examination not giving us an answer as to what really is happening to the baby and the position and the descent inside. Then what about ultrasound examination after delivery? So this is, again, we know that if the placenta is delivered completely in the postpartum period, usually it's 22 is the upper limit of the endometrial lining, so thickness. So if there's anything more than that, then we need to suspect if there's some remnants of the placenta. So this again can be used for various conditions, diagnosed retained placental remnants, and if it can be also be an ultrasound guided removal, or if there's need for ultrasound guided curettage or suction in the postpartum hemorrhage. Also, it can be ultrasound can be used to guide the correct placement of the balloon tamponade in an atonic PPH. And also, of course, diagnosis of rupture, intra-abdominal wall hematomas, then certain rare conditions like placental polyps, arteriovenous malformations, and pseudoaneurysms. And also, as Dr. Girija alluded to, you could also do an ultrasound to help you diagnose occult or clinical pelvic floor or sphincter damages. So basically, right from the time you decide about induction of labor to various dystocias that you encounter during the intrapartum period and also in the immediate postpartum period, there is a lot of interest now to use ultrasound, which can help us to give a very good clinical decision making tool. So in conclusion, ultrasound allows for a more a more objective way of diagnosing the position and the descent and the station of the head. Trans-abdominal ultrasound is most commonly used for fetal lie-in position, whereas transperineal is used for head station. However, real benefits have not yet been proven in large randomized trials, and this requires a steep learning curve for good reproducibilities. But before all of you get very disheartened, I will just end with another on a positive note. I showed you very complicated measurements of the angles, but just the future is around the corner. You have artificial intelligence which is going to help us to measure all of these angles and these distances, and probably there are so many teams that are working on this kind of imaging, and probably we'll just have just an answer given to us by the machine calculating all of these angles and telling us whether this is occipital posterior, whether this is going to be deflexed, or whether we really don't probably have to do much. So hoping that will be the future for us in imaging for intrapartum care. So with that, I will end and hand it over to the moderator and the chair. Thank you again, ICOG, Dr. Jamila, for this opportunity.
Thank you, Anu. Made it so simple. But may we request you to join around 7 o'clock again? Is it possible for you?
Sure.
We will have an interaction, because I think this needs to be actually understood by the practitioners, because we are still in the era of only doing a per vaginal examination. Sometimes we get caught. So we request you to join around 7 o'clock for the interaction, and it would be a great honor. And we'd like to thank you for your presentation, which you made it in. Actually, we called you so late, but it was so wonderful presentation and so useful also. Thank you so much.
Thank you so much. Thank you so much. Pleasure being here.
Thank you. Can we go on to the next talk, Reshmi?
Yes, ma'am.
Shobha madam can introduce the next
I would
speaker.
like to request Dr. Preeti Vyas to kindly deliver a talk on epidural analgesia. Dr. Preeti's slide.
Yes, I'm here.
Kavita, please share her slide.
Yeah, that was a very nice deliberation, Anupama. You did full justice to the subject in the time available. I think I'm not able to see the.
Madam, she's now it's there now.
Now, yeah. So Preeti is the new young FOGSian who is going to kind of, do so many new things. And she's an upcoming consultant. She is an established consultant, of course, but she's going to enter into FOGSi in a very big way after having done a lot of groundwork. Currently, she is the joint treasurer of Mumbai chapter of SUPAP. She is a committee member of MOGS also for the Youth Forum. and peer review of several journals, and national coordinator and trainer for the Youth Mela FOGSI. She has worked very closely with Dr. Suchitra Pandit during that tenure, and past West Zone coordinator and national coordinator for several FOGSI committees as well. She's a prolific author also. So I welcome you, Preeti, to give a very, very, wonderful deliberation. We are all waiting to listen to you. So
Thank you so much,
over
madam,
to you.
for such nice, kind words, madam. Thank you so much, madam. Can I get permission to share the screen?
Yes, we can see the slides.
Yeah, is this visible?
Yes, yes.
Okay, thank you. Thank you so much. So today what I am going to talk about is labor analgesia, but not labor analgesia in all. What I would be talking more about is epidural analgesia. So, I mean, this is something that is very dear to my heart also, because a lot of time we know that it is the most painful experience in a woman's lifetime. And the problem is that many believe, and this belief still continues, that it is fine to suffer and it is wrong to treat the patient. Even in the metro cities, we see the elderlies of the family telling that, oh, you need to learn to just bear the pain, and it is a God's punishment that it was taught. But frankly, women don't need an indication for pain relief in labor. And in fact, the American Society of Anesthesiology, the ASA, has also stated that in absence of any medical contraindication, a maternal request is good enough, an indication to offer labor analgesia to the woman in labor. The pathophysiology is what we need to understand in short, and that is that there are two types of pain when a patient is in labor. There's a visceral and a somatic pain. The visceral pain is there in the initial stages of labor, or the first stage, which is
Preeti,
more
very
towards...
sorry to disturb, but you need to increase the volume of your.
I'll try to talk loudly. Is this okay? Is this okay? Can you hear me now?
Yeah, we can hear, but if you can increase more, that will be better.
My volume is now at maximum, actually. I'll try to talk as loudly as I can.
Okay, it's all right now. We can continue.
Okay. So the visceral pain as well as somatic pain is what we need to look at. The visceral pain is seen in the first stage of labor, which is basically distributed over T10 to L1. And the somatic is seen in the second stage of labor, where it basically involves the pelvic and the perineal structure. And there is compression of the LS plexus or the lumbosacral plexus. So this is a nice picture demarcation of how the pain is. In the early stage of labor, as what you can see here is just the L1, L2. Basically, the patient has some amount of back pain and some amount of menstrual cramps. Then comes the later stage where the distribution of pain becomes larger. Then the early second stage where there is a lot of backache, abdominal pain, and the perineal pain starts off along with the butt pain. And then mainly the pain is near the perineal and the pelvic structures. The analgesia of labor and delivery has always been controversial, and there has always been concerns about the health of the fetus as well as the mother, and what effect it would have on labor, whether it will retard labor, whether it will land up causing more vacuum, more forceps, more instrumental deliveries, whether it will end up pushing a woman into a cesarean section. And this was way back, where Queen Victoria also landed up inhaling chloroform for analgesia during the birth of the Prince Leopold. But what we need to understand is there are options that we have when there are non-pharmacological methods available, such as Lamaze and the hydrotherapy and water baths and all. A lot of people prefer to do that, the acupuncture, the hypnosis. Of course, for those who have a good pain threshold, probably this works well. But for those who just don't have a good pain threshold, it is not as if it is written in a woman's fate to sit and suffer the pain of labor. And the pharmacological methods which we have are the inhaled and the parenteral agents. But today we are not going to talk about it. What we are going to talk about today is the epidural analgesia. Now, an ideal labor analgesic would be one which would not have any side effect, would not cause any hypotension, would not have any effects on the maternal or the neonatal side effects. It will not cause any motor block, but it will also give good pain relief. It will not result in increasing instrumentation, no increase in the cesarean. It will not affect the blood flow to the child, and it will also be cost effective, and it should be personal oriented. Now, that's of course quite an impossibility to achieve probably, but what we see even in USA way back 20 years back also, less than 10% of women were affected by not, I mean, less than 10% of the women underwent childbirth without any analgesia. Something or the other was always offered to them. As against that, in our country, we still need to progress to offering analgesia to all our patients. Of course, regional anesthesia is by far the most commonly used one, and it is the most effectively found to be so, especially so in the metro cities. But what I'm sure you all must have heard Dr. Karthik Bhagat's talk also yesterday about program labor and how they give parental analgesia to patients, and that also has worked very well for them. But when we talk about regional anesthesia, what we use and what we most often prefer is the epidural or maybe the combined spinal epidural block. The less frequently performed nowadays are the lumbar sympathetic blocks or the pudendal or the paracervical block, especially for a patient who's in labor. What are most common or the most definite prerequisites are that the patient has to be counseled, it has to be a verbal as well as a written consent. This should happen all throughout the antenatal visits, especially in the last 2 months or 3 months, where the patient is already primed and already prepared that yes, if you want, you have the choices of choosing whether you want an inhalation or a parental or an epidural analgesia. Do you want a non-pharmacological method or a pharmacological method? The information leaflets need to be shared at that stage. You can't expect a woman who's already screaming in labor to make a decision. It has to be a talk which has already been had, and ideally it is an anesthetist who should be doing the counseling, should take the consent, should make sure that there are no contraindications, and the contraindications have already been ruled out. To perform the epidural procedure, that person needs to be available in the labor room or in the labor delivery suite that is available. The complications, they have to be aware what can go wrong. They should be able to manage these complications properly, and they should be able to order the top-ups well. So let's talk more about the neuraxial analgesia. What we need to understand that it is definitely the most reliable and effective method of reducing pain during labor. However, it can have real as well as predictable risk, and we will see them as we go through in the conversation today. So it's important that first you assess the risk factors for both neuraxial as well as general anesthesia for all these patients. Sufficient time should be available for adequate and safe evaluation of this patient, as well as discussing with the patient, telling them what are they to expect. They should not have any unrealistic expectations from this pain relief method. The routine blood testing which are required are just that yes, the patient should not have low platelet counts and the PTINR should be within normal range. There is moderate amount of clear liquids which are allowed even while the patient is on a neuraxial analgesia. We know that any patient can land up delivering by a cesarean in spite of being in labor and in spite of taking a neuraxial analgesia. So yes, we need to keep things ready for a cesarean for every labor, and that's where we need to make sure that she's not on solids and preferably on clear liquids all throughout her labor. Now, whatever the timing, when is the right time to give her pain relief with epidural analgesia? The current guidelines say that it is the maternal request. When the patient asks for a pain relief, that's sufficient enough a justification for us to give her and to offer her pain relief. It should not depend on how much is the cervical dilatation. Earlier on, it used to be that, oh, the patient needs to be 3 to 4 centimeters dilated, has to be entered into the lactive phase of labor and not in the latent, and only then you can give. However, contrary to that, now the guidelines said that no, it is at maternal request. What are the prerequisites? One, the pre-anesthesia checkup, the consent, make sure there is an IV access already. A facility for resuscitation should always, always, always be there. You need to have a crash cart ready. You need to have the drugs ready. Oxygen should be there. Intubation as well as IPPV facility should be available. And the most important, a 20% intralipid solution. Now, this is something that's not there in most clinics. The reason why this is required is that in case, God forbid, no, but there is a toxicity to local anesthesia, then the only way it can be reversed by giving is at least 2 bottles of the intralipid solutions. Now, how is an epidural anesthesia given? It is most commonly entered between L2 to L3 or L4, L5 space, can be given either at reclining or in a sitting position. What is the difference between administration is that either it can be a lumbar epidural with a bolus and a top-up given as and when the patient needs it. Typically, it's usually between 1 to 1.5 hours that the patient would require a top-up again. Sometimes 2 hourly intervals are required when we are using ropivacaine. A continuous infusion also can be given, but the only problem with a continuous infusion is that there's a small drip that's going continuously, and because it's a continuous drip, there may be sometimes a motor loss also, and sometimes if there is a dislodgement of the catheter, we would not land up getting to know. So at our clinic, we usually prefer a bolus with a topper. Sometimes a combined epidural spinal can be given. Now, this is especially offered when the patient comes in very late stage of labor and we need instant relief at the same time. So the gold standard technique for lumbar epidural analgesia is where low dose of local anesthetic along with an opioid combination is administered either at T10 L1 or, as I mentioned, L2, L4, L5 block during the first stage itself of labor. Advantage of that would be it is safe, effective, there is not much of motor blockade, and it gives the extended surgical anesthesia also if required. As I already mentioned, make sure the history is taken. Contraindications have to be ruled out. Consent has to be taken. A normal CTG has to be documented before a patient is given an epidural anesthesia, and a record of the same must be maintained of the pulse, the blood pressure, the respiratory rate, as well as the heartbeat of the patient. Platelet must be more than 80,000. PTINR must be within normal range. If the patient is on thromboprophylaxis, then you need to be make sure that it's either 12 or 24 hours, depending upon whether it was a therapeutic or whether it was just a prophylactic LMWH going on for this patient. And IV accesses with crystalloid infusion must be going on, and strict asepsis must be maintained. An absolute contraindication would be infection at the site, or a patient in sepsis, or she is already having fever and has some known focus of infection. Also, if the patient already has low blood pressure, or the CTG facility or continuous monitoring facility is not available, or the patient has a condition where there is raised ICT, then it is a complete no-no. But if there are some neurological conditions or cardiac disorders, then of course it is a decision taken between the physician and the anesthetist as well as the as well as the gynec, and it will be a joint decision by all. So this is a demonstration that is being seen in this photographs of how an epidural is given and how the catheter is fixed. Once the space is identified, the catheter would go in very smoothly into the space. The Sharks test is done. You have to definitely rule out an intravascular as well as an intrathecal injection. Blood flowing out through the catheter or CSF coming out to the catheter is a complete no-no. You need to abandon the procedure immediately and then maybe go at a second space. The heart rate increases by 30 beats if it is an intravascular injection. So we need to be sure of that. We have to definitely give IV fluids, do a continuous monitoring, make sure that the position is checked. What about the test dose? Test dose is most important. Every time a top-up is given or a bolus is given, a test dose must be done. You have to make sure that it is not inadvertently moved. It is not gone into the intravascular or intrathecal space. The drugs which are used are bupivacaine or a ropivacaine and an adjuvant. Usually fentanyl is what is added. The duration of action depends on what drug we use. With the bupivacaine, usually it's around 1.5 hours. It will be a little longer with a ropivacaine of up to 2 hours. A very dilute dose of as low as 0.0625 can be actually given, and the patient can be having a walking or a mobile epidural, as what we call, where there is hardly any motor blockade for these patients. The long duration of action of bupivacaine makes it a very popular agent for labor, and ropivacaine is especially preferred when we are worried about cardiotoxicity. What are the complications we are worried about when a patient is given epidural analgesia? The most important is hypotension or an unintentional intravascular or intrathecal injection, which can result in a post-dural puncture headache, abscess or an infection or a hematoma there, and very rarely a neurological deficit because of the damage to the spinal cord. So initial dose is given, followed then by either a bolus or a confusion. Every dose is considered as a test dose. After every dose, at least 5 minutes, you have to wait for it to ensure that the blood pressure is stable before giving any further drug. No significant loss of power should happen in the legs. A loading dose would take at least 5 ml of 0.5% of bupivacaine and dilute it to 10 ml to get a 0.25% concentration. To this, 25 microgram of fentanyl is added, and then this is given slowly, as I mentioned. The maintenance dose of epidural can be 50 ml, which is a prefix syringe, and keep giving repeatedly at intervals as required, monitoring the vitals at all levels. Monitoring the level of the block at all level also should always be done. And the vitals have to be monitored every 5 minutes for the first 15 minutes. If after that it is stable, then we can reduce it to monitoring every hourly. An epidural infusion is also used by some people. I prefer not to. I usually prefer at my clinic bolus followed by, loading followed by bolus doses. The assessing and recording of the sensory level of block at every hour is important whenever a patient is under infusion, and the anesthetist has to be available immediately, cannot start and the patient cannot be put on the drip and the anesthetist goes and finishes up call. No, that's never done. It's important to monitor the sensory block with an ice pack. T10 would be the midpoint of umbilicus. T8 would be from umbilicus to fundal region. T4 is above the nipples. And if it goes above that, then it is level D or danger. And what if you are in the danger zone? First thing,
Preeti, sorry to interrupt. You've got 1 more minute, Preeti.
Sure. So first thing, immediately stop the infusion, start oxygen, call the anesthetist and have the crash cart ready. Epidural analgesia, which is patient control, is not something that we use in our country. We make sure that monitoring is done and top up is considered as a new dose every time, giving a test dose. A higher concentration of local anesthetic with a pudendal nerve block can be given in addition to a epidural if required. And if there are any warning signs like difficulty in breathing or arousing the patient or heaviness, tingling in the arms and legs, immediately call the anesthetist. The complications I already mentioned, hypotension, bradycardia, respiratory consequences or a total spinal and neurological complications is something that we need to be aware of. Suppose there is a dural puncture, the first thing is give left lateral in cases of hypotension, give IV fluids, give oxygen, give vasopressin if required. In a higher or total spinal, we may have to even intubate the patient. And for a post-dural puncture, we may even have to put in a blood pen. Most important, while removing the epidural catheter, please make sure that the tip is always checked.
Preeti,
People
Preeti.
and documented so that there is a thing. It's almost last 2 slides left.
Okay.
Okay. Once the epidural is removed, make sure the vitals are monitored every 4 hourly for the next 12 hours, even after removal of the epidural, and follow up in case the patient has any headache, backache, or a progressive numbness or weakness in the legs for more than 3 hours after removal of the catheter. This patient needs to be monitored and a physician and anesthetist both have to be available. So to conclude, individualized technique is required for depending on the patient's goals, the stage of labor and their wishes, as well as optimizing spontaneous delivery. It has to be safe and cost effective at the same time. These are just some forms that I have got from this thing about the information card, which can be distributed to our patients before we give them an epidural analgesia. Thank you.
Shobha madam. Thank you, Preeti. Thank you so much. Can you stop sharing? Wonderful talk. I think we'll have the discussion at the end of the session.
Yeah, I think we'll have the discussion at the end.
At the end,
yes. Yeah, let us start.
Yeah.
Thank you.
Kavita, please share the screen of your Reshmi and yours, because we forgot to introduce the convener and coordinator for the day. The previous slide.
Is it seen?
No, yours and Reshmi's. Reshmi is the chairperson of the Practical Obstetrics Committee. She'll be giving the talk after mine. And she's also the chairperson of the High Risk Committee of AMOGS. And she's a great worker who works tirelessly. And she's one of the, I would say, one of the best people in FOGSI always. Reshmi, thank you for the help in convening the program. Next, it is Kavita. Kavita, yours. Kavita is a coordinator for the day. I think somebody needs to mute themselves. Reshmi, please mute yourself. Yeah. And she's a professor and head at the Department of Obstetrics and Gynecology at Ludhiana. Okay, I muted her. And she's the vice president of the Ludhiana Obstetrics and Gynec Society, president of the Ludhiana Menopause Society. She's won several awards, which includes a Best Clinical Teacher Award, a Wonder Foxian Award, a Manyata Champion Award, Best Editor Award, and the FOGSI Achiever Award. And interests are in high-risk pregnancy, infertility, and preventive oncology. And thank you, Kavita. You can stop sharing now. Then you can, otherwise you share Radhika's, because Radhika is the chairperson for the next session. I'd like to thank Radhika for joining the program today. And we would like to invite you for the ICOG conference, which will be held in Pune from 28th Feb, 1st and 2nd of March. There's a wonderful talks, great faculty have accepted to come. There'll be the convocation program also. We request that all of you join in big numbers and make the program a success, because it's the academic part of FOGSI and we need to be involved to make it much more bigger. Thank you for attending this program, and we hope you enjoy the program. Kavita, please introduce Dr. Radhika. You have to unmute yourself. Kavita, you have to unmute yourself.
Charmila, it looks like the host has to unmute.
Shreya, please unmute Dr. Kavita. She's a coordinator. Shreya.
Now am I audible?
Yeah, you're audible now. Yeah, please introduce.
So, session 2, chairpersons, we have Dr. A.G. Radhika and Dr. Vinita Singh. So Dr. A.G. Radhika, she is a great academician, senior consultant, OBGY, University College of Medical Sciences and GTB Hospital, Delhi, and has been a member of Geneva Foundation, Cochrane Collaboration, South Asian Cochrane Network, and Campbell Collaboration. A great academician, and we look forward to her inputs for the next session.
Please make Dr. Reshmi as a co-host. She has joined again.
And
Reshmi, she's already joined. Yes, yes. Radhika, please continue.
The next chairperson is Dr. Vinita Singh.
She's not joining, Kavita. We can go ahead with the program.
Okay. So Dr. A.G. Radhika, if she's there.
She's there.
Ask her to introduce.
Radhika, no need to
very
introduce.
good afternoon. Thank you very much. So I think, so Charmila, you're going to be there as a...
Yeah. Speaker
so,
now.
Okay. Yeah, sorry.
No problem.
Warm welcome to you, Charmila. So
yeah, we'll start this.
I think Charmila is well known to all of us. So great friend, I would say great academician, and she's an all-rounder. She's a director of Aditi Hospital in Parvati Ayavu Fertility Center at Trichy, AP Dhanlakshmi Srinivasan Medical College, Perambur, consultant South.
It's okay, Radhika. I think we'll start.
I think she has been very modest in putting her accolades here. I would say it will run into 3 slides. So welcome to you, Charmila, and over to you. We really would like to hear from you.
Yeah. Thank you, Radhika. Thank you so much. I'll just share my screen. There have been wonderful talks on the labor phases, but there's always a controversy, and I'm seeing in the chat box also people asking like which is actually the active phase and which is actually the latent phase. I'm still admitting people. So when we want to talk, please.
Don't get distracted. I will do that.
Yes. Normal labor has been first categorized by Friedman, and yesterday the talk was there by Saraswati Madam, and today Girija also talked about that. And this we know already that there are 3 phases, but the labor disorders have been described by Cohen and Friedman, and that came out in 1983, where they have said latent phase can be a prolonged latent phase when it's considered as a disorder. In the active phase, you've got 2 types of disorders, and that is the protraction disorders and the arrest disorders. And the third is the descent disorders, which can happen in the second stage. According to the WHO partogram, the latent phase is around 8 hours, and the active phase should start at 4 centimeters dilatation and should be 1 centimeter per hour dilatation. And alert line is if the active phase is not 1 centimeter per hour dilatation, even after 4 centimeters when the active phase is started. And action line is 4 hours to right to the alert line. So suppose you have a slow active phase, according to the WHO partogram, you have to wait for 4 hours before you diagnose. And that's what the thinking came, like because of these labor phases which came so late, so early, like 50 years back, these labor phases have been defined, and we are still following them. And that's why the thought came whether, because the increasing cesarean rate may be because of these outdated definition of labor phases. And that's why 2 workshops were held by the American College, and they depended on the National Institute of Child Health and Human Development sponsored Safe Labor Consortium report by Zhang and his associates, and they brought out these ideas. And in that they said the primary cesarean rate has increased because of changes in the labor phases, and they say first stage arrest contributes to almost 15 to 30% of cesarean sections, and second stage arrest contributes to almost 10 to 25% of the cesarean rate. So that's almost like a 60% rate maybe because of the labor disorders being defined in a different way. So they did a study in 2010, which is called a Safe Labor Study, where it was a retrospective study. They collected data from 19 hospitals in America. They took 62,000 parturients and they considered only the delivery of a singleton vertex vaginally, and the baby should have had a normal perinatal outcome. And they defined the normal labor progress based on this study. And the findings of the study was normal latent phase can have a very, very wide variation. And diagnosis will actually depend on the cervical examination at admission and parity. You do not know when she has actually started her labor phase and what is the cervical examination, which could happen even earlier. So only at admission we are diagnosing. We don't know what has happened earlier. And they said the active phase dilatation was substantially slower than what has been derived from Friedman curve. And they said the transition to the active phase actually starts later and it's achieved at 6 centimeters compared with the Friedman definition of 4 centimeters. This is what the comparison said. And the cohort of Friedman was 1,000 parturients, but this study had 62,415 parturients at term. And they said the latent phase is 20 hours according to Friedman, but this curve said it can be between 4.5 to 15.7 hours. And they did not define a latent phase for a multiparous individual. And the dilatation is not 1 centimeter per hour. They said it can be less than 1 centimeter per hour until 6 centimeters of dilatation. And the rate of cervical dilatation in active phase is also much slower than what has been actually said by the Friedman curve. And the second stage duration can be almost 3.6 hours with an epidural and 2.8 hours without an epidural. So you can actually wait when the patient is fully dilated for almost 3 hours without an epidural when the patient is a nullipara. And you can wait for almost like 2 hours for a multipara. So the moment we see the baby on the perineum, we try to deliver as quick as possible. I think that thought should go out of the mind. You can wait for 3 hours for the baby to deliver after full dilatation. And this is what they said. It takes almost 6 hours to dilate from 4 centimeters to 5 centimeters. And it takes the next 3 hours to dilate from 5 centimeters to 6 centimeters. That is, you can wait for 9 hours for the patient to dilate from 4 centimeters to 6 centimeters. And that is a huge number. And they said up to 6 centimeters, both the nulli and the multipara will have similar curves. And after 6 centimeters, the multipara will dilate much faster compared to a nullipara. But they're very clear that the active phase starts only at 6 centimeters dilatation. And this is the comparison between the American College and the Royal College. But both have agreed that the dilatation need not be 1 centimeter per hour. A dilatation of 0.5 centimeters per hour can be accepted in the active phase. And they define arrest in the first stage as no progress with oxytocin for then the contractions are adequate for almost 4 hours and still the patient is not progressing, then you tell it is arrest and not before that. And suppose the patient is having inadequate contractions, you can wait for 6 hours before you say that she is arrested. Royal College says no progress after 4 hours of oxytocin is the arrest in the first stage. And as I said, second stage is much longer according to the American College than what has been talked about earlier. So what is the reason for the change in these curves? Maybe the maternal characteristics have changed, maybe an increasing maternal age for pregnancy. Probably the maternal and fetal body sizes have changed and made obstetrics a challenge. Maybe we are using too much of obstetric interventions like induction of labor, epidurals and oxytocin, and they could have altered the natural labor curves which have been identified earlier. There are 3 changes from the 1960s which has caused a change in the obstetric management, and that is we know that the prolonged labor can cause maternal neonatal morbidity, and that is one reason that we intervene a little early. And dilute oxytocin usage can cause an uterine dysfunction by itself when it's actually used to help the labor dystocia. And nowadays, cesareans are preferred to a difficult mid-forceps delivery, and the labor disorders have become probably a different ball game now because we understand it much differently. So has the method of changing the definition of normal dilatation prevent the preventable cesarean for which these studies have been done? And this was the study, these are the 2 studies which were the basis for the Friedman's curve. And in that actually 1,000 parturients, not 500, in that 38% had spontaneous delivery in that cohort of 1,000 parturients. 55% had an outlet forceps delivery. And in that 0.9 was mid forceps, 2.8 was breech, and 0.9 was twin births. There was only a 1.8% cesarean delivery, and there was a 0.9% stillbirth and neonatal deaths. But the main characteristics which were the reason for the Friedman's curve was 70% of the women in that cohort were between the age of 20 to 30, which is quite rare nowadays. And many babies in the delivery group had a normal weight range of 2.3 to 3.6 kg. And in almost 13.8% of the patient, they use oxytocin for induction or augmentation. And they put the patient to twilight sleep during the labor process. And that is 96% of the women were sedated with drugs when they were in labor. And the results were 8.6 latent phase, active phase was 3 centimeters per hour, and time between 4 centimeters and 10 centimeters was only 5 hours, and second stage lasted for 1 hour, according to the Friedman's study. So when there was a comparison between these two curves, that is the Friedman curve and the Zhang curve, and it was a prospective study which was done in Italy. 419 women were enrolled, half had care based on the Friedman's curve and half had care based on the American College guidelines. And in the Friedman's curve, the food was banned. The laboring women were restricted to bed, and they were asked to push on the backs. In the American College model, it was used as a screening tool. More patients were there with the labor, and assessments are done a little rarely. They did not do interventions often. Mothers were encouraged to walk, and they were asked to push and give birth in the position they found most comfortable. They were given free access to food and drink, and the standardized protocol was used to diagnose fetal distress. And the results were cesarean rate was more in the Friedman's model compared to the new model. And the new model had fewer interventions and fewer had oxytocin or ARM. And there were a low UPGAR scores, a low umbilical cord pH in the Friedman group compared to the new model. But the average length of labor was quite same in both the groups. So the acceptability was much better with the newer model compared to the Friedman model, but it did not make any change in the average length of labor. And after the American College brought out its guidelines, there was a rebuttal by Cohen and Friedman in 2017. And they gave the presentations in two papers, and that was the perils of the new labor management guidelines and the viewpoint that is a misguided guidelines for managing labor, and that was published in the American Journal. And they said American College of Obstetrician Gynecologists guidelines have ignored half a century of corroborated research, and it's a testament to the triumph of theory over experience. And they said the sigmoid curve has changed to exponential curves in the Zhang study. But you have to remember that the nature of progress in labor has not actually changed, but the data were analyzed much differently in the two studies. There are lots of selection biases and uncontrolled confounders in the Zhang study, and that cast a doubt over the validity of the findings. And in the Zhang study, the cesareans were not included at all. So cases of dysfunctional labor were not analyzed. And the study also excluded women whose cervix was more than 6 centimeter dilated at admission. And it ignored the most rapid labors, and that contributed to supposedly the slow average dilatation, which was found out in the Zhang study. And they did not include the compromised newborns. And that means you do not know how many babies went for a distress when you waited on labors for almost 9 hours between 4 to 6 centimeters dilatation. And these major exclusions make the acceptance of the new guidance difficult, as per Cohen when he gave out the rebuttal. And the overall cesarean rate in both were, the safe labor concession was 30.5%. So it hardly caused any fall in the cesarean rate, but when it supposedly it was started for that reason, where they wanted to decrease the cesarean rate. So the new proposed first stage intervals did not make any change at all. And we know that Iron Donald said that dawn should not rise twice upon the semen labor. But when you want to wait for 9 hours between 4 to 6 centimeters, it's going to cross the day, because latent labor is also long and active phase is also can be a long drawn process. And that's why the American College has not changed much of its guidelines, but it said do not offer that active management of labor, which was brought out by Driscoll, because that actually causes more of cesareans. But they said you should offer one-to-one continuous support. You have to have a strict definition of established labor. You have to do an early routine amniotomy as an intervention. 2 hourly vaginal examinations are allowed to identify whether labor is progressing. And you can start oxytocin if the labor becomes slow. The 24th edition of Williams Obstetrics has said, when you increase the duration of second stage beyond 3 hours with an epidural, adverse infant outcomes definitely happen. And still the diagnosis of dystocia is elusive. The new definitions may not have a great impact on cesareans or abnormal labor. And that's why we need to have safety when you're following the second stage labor guidelines, which the American College has brought. And there were studies which wanted to know the impact of the new guidelines on the cesarean rates. And this was one study which was published in 2023. 192,405 deliveries across 40 hospitals, and they all had the deliveries based on the ACOG recommendation, but the cesarean rate reduced just by 1%, 25.8 to 24% when it considered nullipara term singleton vertex as in the Zhang study. And the decreases were more in non-Hispanic white women, but not among non-Hispanic Black women or Asian Pacific Islanders or Hispanic women. And the same pattern of no reduction cesarean rate was also observed in teaching hospitals, and there was no change when it was compared to non-teaching hospitals. And I have to summarize by saying that there's one trial which was published in 2023 called as a REDUCE trial. It was a cluster randomized trial for reducing the utilization of cesarean delivery for the reason of dystocia. And this study aimed to assess whether adoption of the new guidelines for diagnosing non-progressive labor could reduce the cesarean delivery rates. And it said categorically that there was no reduction just because you changed your guidelines. And I would like to conclude by saying to take it wisely and slow, because we will stumble if we run fast. And that's why William takes you. Thank you so much.
Thank you very much, Charmila. That was an excellent talk. I think the entire debate in a nutshell and the pros and cons presented extremely well. So as regard the change in the practice, so I think ultimately when it comes to labor, as we become older in the trade, whatever be the guidelines, lot of experience determines what we finally do, isn't it?
Yeah.
So even if what is written there, you give this, give that, you feel the cervix is soft, the head is entering, so it is So, but I think in India, with the kind of practices that we have, again, for us to have our own guidelines, we need to publish our results. And to be able to counter what is in existence, is it any different for us? Though we do not expect it to be so, but it is important for us to at least have some sort of standard practice protocol.
Yes.
Number two, I was wanting to know about your thoughts on the labor guide that has now come. So because now they have, the entries and the checklist form the nature of that graph easy to maintain and easily auditable.
Radhika, we have got a separate talk on that by Dr. Ishita tomorrow, and they have done a multicentric trial throughout India on the utility of the labor care guide. I think we can ask her the question there then, because they have done the analysis of so many centers based on the labor care guide. I think we can ask her tomorrow. There is a separate
I
talk
think
on that.
that would be really nice to
Yeah.
be able to hear that.
Yeah.
So any other questions from any other people?
Radhika, we are running like short of time.
Short
We'll
of time,
go
okay.
to the next
So
session.
we'll go to the next session, please.
Reshmi, please. We have already introduced Dr. Reshmi.
Yes,
I think she can
thank
start.
you so
Okay,
much.
Rashmi, over to you, please, Dr.
Yeah,
Rashmi.
thank you
Welcome.
very much, Radhika madam. Thank you, Dr. Parag Viniwale sir and Dr. Shamila madam for this great opportunity. I will be talking on meconium stain amniotic fluid and labor. Meconium stain amniotic fluid is considered an obstetric hazard since centuries. Not all green stained amniotic fluid is meconium, and not all meconium is green. Meconi, it has been extracted from this word meconi, which means poppy seeds, which induces sleep or neonatal depression. So the green stained amniotic fluid, often referred as meconium stained amniotic fluid, is present in 5 to 20% of patients in labor and is considered as an obstetric hazard. The typical greenish yellow color of meconium is attributed to bile pigment, bilirubin, a product of heme catabolism, and is a main ingredient of meconium, and it is detectable in fetal liver and gallbladder from 14 weeks onwards. So what is the composition of meconium? It consists of water mainly, 70 to 80%, intestinal epithelial cells, maybe squamous cells, Lomix gaseosa, fetal hair, amniotic fluid, bile pigments, bile acids, pancreatic enzymes, and some pre-fatty acids. So meconium, since so many years, so many researchers, they have shown that there exists a linear association between the meconium and low Apgar square, decreased fetal heart rate, and increased chances of cesarean deliveries. Meconium is considered as an obstetrical hazard, and many authors have confirmed that meconium stained amniotic fluid is associated with neonatal death. Not only that, it is also associated and is hazardous because it results in neonatal hypoxic encephalopathy, neonatal sepsis, seizures, and cerebral palsy in neonate. So what are the risk factors for meconium stained amniotic fluid? the primary risk factors are postpartum pregnancy, prolonged labor, clinical chorioamnitis, fetal growth restriction, preeclampsia, most common oligohydramnias, vaginal breech delivery, some maternal drugs like cocaine or castor oil or purgatives, herbal substances, or intrahepatic cholestasis of pregnancy can lead to meconium-stained amniotic fluid. And what are the factors associated with meconium-stained amniotic fluid? So there are three factors we can consider. The first is the gestational age, second is the fetal hypoxia, and third is intra-amniotic infection or inflammation. So when we talk about the gestational age, the rate of the meconium-stained amniotic fluid, it increases as the gestational age of the fetus go on increasing. And at around 42 weeks, near about in 27% of the fetus, the amniotic fluid is meconium-stained. And because as we know that as the gestational age increases, there occurs maturation of gut. And there is also a subset of infants or neonates which are postpartum but are growth restricted. In those infants also we can see meconium-stained amniotic fluid. Motilin, it is gut hormone. It induces intestinal peristalsis in neonate and it is found at term. Similar is cortisol. It is seen mostly at the time of delivery and it induces peristalsis in neonate, and also corticotropin releasing hormone has the same action. The second important factor to be considered is fetal hypoxia. So meconium-stained amniotic fluid is associated with fetal acidemia and chronic hypoxia. It is very widely believed that the fetal hypoxia is going to lead to meconium passage. But frankly speaking, do we have any robust data to prove it? No, we do not have much studies that can conclusively prove that fetal hypoxia leads to meconium passage. Why? Because there are many neonates born with maternal meconium-stained amniotic fluid and they do not have any metabolic acidosis at birth. Moreover, in many animal studies, it has been seen that normal fetal defecation is not associated with any acidemia or hypoxia. Even repeated cord compressions done in animal studies did not result in any meconium-stained amniotic fluid. So this controversy in studies is going to affect the tools of surveillance of fetal well-being in meconium-stained amniotic fluid deliveries. And a third important factor to be considered is intra-amniotic infection or inflammation, which is associated with meconium-stained amniotic fluid. It is associated with microbial invasion of amniotic fluid in term and preterm gestation also. The green discoloration is either due to passage of meconium or oxidative stress in amniotic cavity. Microbes can cause inflammatory reaction leading to reactive oxygen radicals, which can bring about the oxidation of heme catabolic products, mainly the bilirubin. So how can we assess the meconium-stained amniotic fluid? So there are two important parameters we can use. First is the ultrasonography, which is not very sensitive or specific, and second is the serial amniocentesis. So ultrasonography is comparatively non-specific parameter. If we can see diffuse echogenic pattern in amniotic fluid or clear contrast between the amniotic fluid and umbilical vessels, or if we can see layering in the dependent parts, dependent areas, then we can say that yes, the fluid is meconium stained. And the second parameter is serial amniocentesis. We can grade the meconium as which is green or yellow, is green or yellow with particulate matter. And grade 3 meconium is dense meconium with pea soup consistency. And there are also two terms very commonly used, like the thick meconium or the thin meconium stained amniotic fluid. So meconium-stained amniotic fluid is definitely going to affect both the mother and the fetus. The neonatal outcomes will be either there will be abnormal fetal heart rate racing, meconium aspiration syndrome, neonatal intensive, the neonate may need admission to neonatal intensive care units. There may be need of neonatal ventilation. The neonate may have hypoxic ischemic encephalopathy. They may born gestationally, they have low ABGA score, and in mother, she may have more chances of cesarean delivery, puerperal endometritis, clinical chorioamnitis. She may have intrapartum fever or intraamniotic infections. So neonatal implications of meconium amniotic fluid, and the most common implication of this is meconium aspiration syndrome. It is a grave consequence in neonate. Meconium stent amniotic fluid can cause meconium aspiration syndrome, neonatal sepsis, neonatal seizures, and cerebral palsy. It is the cause of neonatal morbidity and mortality. It follows intrapartum or antepartum hypoxia, leading to meconium passage, meconium aspiration during birth. But not all the neonates with meconium aspiration syndrome have acidemia at birth. Mechanical causes also, like the meconium aspirated, may cause airway obstruction in the neonate, leading to atelectasis or air trapping into the bronchioles and alveoli. Meconium also has a chemical effect, like the contents of the meconium, like bile salts or free fatty acids, they can cause surfactant inactivation, leading to local inflammatory changes, responses, and that results into the decreased pulmonary functions. So as we can see, there can be a physiological passage of meconium due to the gut maturation that will stain the amniotic fluid with meconium. The baby may have aspiration after birth or in utero, leading to meconium in lungs, causing air obstructions, surfactant activation, and chemical pneumonitis. And baby neonate may present with mild meconium aspiration syndrome. The neonate will have hypoxemia, features of hypoxemia. Moderate meconium aspiration syndrome, in which the neonate will have hypoxemia and hypercapnia, and severe meconium aspiration syndrome, hypoxia, hypercapnia, and acidosis. So important thing is that this fetus, where there is physiological passage of meconium, may all have compromise. And when this passage of meconium is added with fetal compromise, there will be continued fetal compromise more, and the neonate will have pulmonary vascular remodeling, leading to persistent pulmonary hypertension. So the exact pathophysiology of meconium aspiration has been the subject of much debate, but the accepted views is when the meconium is passed and there is acidosis that induces fetal gasp, the meconium is aspirated by the neonate in utero, leading to asphyxia, and it leads to initiation of pulmonary hypertension. So there are some robust studies. They really believe in that intrapartum and amnio infusion in meconium stained amniotic fluid can help to a large extent to the neonate. They say that the presence of the thick rather than the thin meconium has adverse effects on neonate. And so they also believe that installation of normal saline in uterus, it was said to reduce the concentration of meconium, bringing about dilution and thus reducing the aspiration. Amnio infusion also corrects oligohydramnios and prevents cord compression. And the nasogastric tube can be inserted transcervically, reaching just above the cervix, and the normal saline at room temperature is infused over 30 minutes, 3 ml per hour. 500 ml can be given in one go, and again can be repeated. This has to be followed and monitored continuously with electronic fetal monitoring. Auscultation has to be done every 15 minutes, and this is a very cheap and effective method according to this study. So when the amniotic fluid is meconium stained, we have to inform the relatives, put the patient on continuous electronic monitoring. We have to take the consents because the patient might need some interventions, and a team of the neonatologists or the pediatricians, they have to be informed about the patient.
Dr.
If the
Rashmi,
patient
sorry
presents
to Dr. Rashmi, sorry to interrupt. I think only 2 minutes left.
Yeah, if the patient presents with PROM and the meconium is thick, we have to review the plan and go for induction of labor. Plan of the management in the patient is going to depend upon whether the meconium is thick or thin, stages of the labor, parity of the patient, associated risk factors, and if she is at the primary reference center, how much time we have to refer to her to reference center. And there are some guidelines. If the patient with the meconium stained amniotic fluid enters the labor room, we have to admit the patient, and we have to admit the patient to the obstetric unit. If there is significant meconium stained liquor, we have to go for continuous monitoring. We have to induce the labor, and a plan of induction should be made considering all the factors which are affecting. And if there is PPROM, an antibiotic has to be started. Also consider corticosteroids and magnesium sulfate. If there is early thick meconium stained liquor in early labor, please plan for an urgent cesarean delivery should be considered for this patient. Neonatal resuscitation in meconium aspiration syndrome is also very important. Strictly avoid intrapartum nasopharyngeal suctioning of newborns who are delivered through meconium amniotic fluid. Give initial care. If the baby is vigorous, neonate can stay with mother. Give initial steps of neonatal care. A bulb syringe can be used to gently clear secretions from nose and mouth. Say, for example, the baby is not vigorous, they put the baby on radiant warmer, clear secretions with bulb syringe. Proceed with normal steps of neonatal resuscitation like warming, repositioning of head, drying, stimulating. Consider positive pressure ventilation in this baby. But there are some things to ponder. So we have been continuously using this term thin or non-significant meconium. And we say that these patients come into the low risk category because they have thin meconium or they are low risk. And then we say that these patients can be auscultated every 50 minutes and this much monitoring is enough for this patient. Thin or thin, but in my opinion, they are equally hazardous and carry equal intrapartum risk factors. Why? Because thin, the meconium may be thin or thick, but it only depends upon the Leica volume. The fetus is surrounded by toxic meconium. It may cause local damage like damage to the umbilical cord in the form of severe ulcerations, physiological disformation of fetal skill, chorioamnitis, and endometritis on prolonged meconium exposure, and decreased lung compliance and meconium aspiration syndrome in fetus. So there are both local and systemic effects of meconium, irrespective of whether it is thick or thin. Both are strong risk factors, and both warrants continuous fetal monitoring in this patient. So light meconium, thin meconium, thick meconium, these are all, have these terms all equal, or light, thin, are these terms non-significant? No. Both terms like thick or thin, light, all the meconium is hazardous locally and systemic. They both, in both ways, they have the effect on neonate. We need to do continuous monitoring of this patient. It indicates, the presence itself indicates and alerts us about fetal hypoxia, infection, and meconium aspiration syndrome chances. And it is very significant from a fetal point of view, which is surrounded by toxic material within the surrounding amniotic fluid. So the only quote in recent times I like is the quote, is the message posted by Dr. Shamila Ayawo, madam. She has said some 2-3 days before, we are one of the countries with the highest number of births in the world, and we follow the American Treatment and the Chang guidelines defining labor disorders. And so we really need to make our own guidelines. Thank you very much.
Thank you so much, Dr. Rashmi. I could not agree with you more. We certainly need the guidelines.
And you are the very, very apt person to be there, Radhika. I think it was God's choice that you should be there, because she's one of the persons who can really make the excellent, I would say, guidelines for our country, and she has to be utilized for that. And you are the future for us, Radhika. We'll ask your help. Yeah.
Thank you so very much. So take home message is, Dr. Rashmi, that any type of meconium is important and has to be dealt with equal seriousness. So thank you very much for that message. So can we go on to the next speaker, please? Can I have the next introduction slides, please?
I think Madam has already flashed. I think you can talk from that only.
Okay. So the topic is vaginal birth after cesarean section, extremely important and very relevant in today's context. So we have with us Dr. Suma Natarajan. She's the head of the department at Ganga Women and Child Center. She's the director of SJ Craft Fertility Center. Warm welcome to you, Dr. Suma, and over to you, please.
Before we start, I would like to actually welcome Dr. Sheila Mane, madam, the vice chairperson elect for ICOG. Madam, would you like to say a few words before we go on to the program? And please unmute Dr. Sheila Mane, madam. Please make her a co-host. Sheila, madam?
Yeah. Now they have. Yeah.
Yes, ma'am. Yes,
oh, thank you, Dr. Charmila. And it is nice to see that so many people, 446 people have logged in. And the topic today is related to labor, I think, which is equally important. Because certain things, unless and until we really try to discuss again and again or debate and reinforce, it will be, we will not be will not bring the seriousness, because we know that with the rising incidence of cesarean, with the rising incidence of cesarean section, it is sorry, it is very important that labor management is equally important. I can see the speakers, from yesterday we are discussing all the details about labor analgesia, and now Dr. Suma is going to talk about VBAC, Dr. Charmila's talk, and none other than, as Dr. Charmila mentioned, Dr. Radhika. I think Dr. Radhika Charmila said it, okay? And we really have to work for that, because we know that our numbers are more, and unless and until we look at our ethnicity and our problems, which will really guide us properly. So we look forward to you, and I really want to thank Dr. Parag for conducting this certificate course, as well as all the speakers for giving their prestigious time for this certification course. And I welcome all the delegates, and I would like to thank all the delegates for logging in for this knowledge cafe. Thank you.
Thank you so
Chandra,
much, ma'am.
Thank you so much,
Kid.
ma'am.
Thank you, ma'am. Suma, madam, you are visible. If I talk to you, you are audible also.
Can you hear me?
Yeah, we can hear you. We can hear you. You can continue.
Dear chairpersons and my dear friend Chami, my topic given was vaginal birth after the cesarean section. I bring greetings from Ganga Hospital and SJ Clinic. And we all know that there is an alarming increase in the incidence of cesarean section worldwide, from 8.4% to 21.5%. And WHO recommends a 10 to 15% incidence. And there has been an alarming increase in India also, because maybe because of increase in the IVF pregnancies, increased maternal age, request for a section, fear of litigation. So this translates to increased repeat sections, leading to increased financial burden on the nation's economy and increased maternal and neonatal morbidity. So there is an urgent need to optimize the Caesar rates, both to reduce the primary cesareans and to encourage TOLAC. Now, what are the options for a patient with a previous cesarean? One is to go for an elective repeat cesarean section, which is either called as ERCD or ERCS. And the other one is trial of labor after cesarean section. Now, this TOLAC has got two outcomes. A successful TOLAC is where you have a vaginal birth after cesarean delivery, otherwise called as VBAC. And a failed TOLAC is where you have an emergency cesarean delivery. Now, who are the women who are best suited for having a planned VBAC? A planned VBAC is appropriate for women for or may be offered to the majority of the women with a singleton pregnancy of cephalic presentation at 37 weeks and beyond, who have had a single previous lower segment cesarean delivery with or without a history of previous vaginal birth. Now, this is a little busy slide. This shows the risks and benefits of vaginal birth, planned vaginal birth, and emergency elective repeat cesarean section. Now, if you look at the maternal outcome in a planned VBAC, 70 to 75% of them have a chance of successful VBAC, only a 0.5% risk of uterine scar rupture, increased likelihood of future vaginal births and instrumental delivery of almost up to 39%, and the risk of maternal death is only about 4 per 1 lakh. The infant outcome, if you look at there's a risk of transient respiratory morbidity in 2 to 3%, and only 0.08% risk of HIE. Now, if you look at the elective repeat sections, they are able to plan a known delivery date in these patients. And this is what happens in want to have a good day, a good time and all that. They avoid the risk of uterine rupture, longer recovery, and it reduces the risk of pelvic organ prolapse. The option for sterilization if fertility is no longer needed. But then the future pregnancies are likely to require cesarean deliveries, which may increase the risk of placenta previa and accreta spectrum disorders, and additions with the successive cesarean deliveries and abdominal surgery. The risk of maternal death is much more than that of planned VBAC. It's around 13 per 1 lakh. And the risk of transient respiratory morbidity is about 4 to 5%, and less than 1 per 10,000 risk of HIE. Selection of candidates for VBAC.
Madam, it was seen, madam. It's there.
No, that's different.
Okay.
No, sorry.
Now it's there.
Okay. Selection of candidates for VBAC are those with a previous low transverse cesarean delivery, a clinically adequate pelvis, no other uterine scar or previous rupture, a physician immediately available throughout the active labor, capable of delivery.
I think there is a problem with the connectivity.
The factors influencing the success of VBAC are the type of prior uterine incisions, prior uterine rupture, the closure of prior incision with a single or a double layer closure, interdelivery interval, number of prior cesareans, prior vaginal delivery, indication for prior cesarean delivery, fetal size, multifetal gestation, and maternal obesity. Let us look at all these factors one by one. Now, coming to the type of prior uterine incisions. Now, the incidence of rupture rate with classical in T-shape is around 4 to 9%, low vertical 1 to 7, low transverse 0.2 to 1.5%. Prior uterine rupture, if the patient has had a prior uterine rupture of lower segment, it is 6%, and upper uterine, it is around 32%. Now, coming to the closure of the prior incision, either single layer or double layer, Chapman in 1997 and Tucker in 1993 said there is no relationship between a single or a double layer closure and the risk of subsequent uterine rupture. Whereas in 2003, Dernwald and Mercer, they said no increased risk of rupture, but they reported that there is a uterine dehiscence in a single layer closure. Now, Bujold and co-workers in 2002 said single layer closure was associated with nearly 4-fold increased risk of rupture compared with a double layer closure. Now, coming to the interdelivery interval, at least 24 months between the date of the last cesarean and the date for this pregnancy increases the chance of successful VBAC and decreases the risk of uterine rupture. Ship and Associates said intervals of 18 months or less were associated with a 3-fold increased risk of symptomatic rupture during a subsequent trial of labor compared with intervals of less than 18 months. Now, the number of prior cesarean incisions, Miller and colleagues in 1994 said rupture rates of 0.6% following one Caesar and 1.8% following 2 prior Caesars. Whereas McCones and Associates said 2 prior cesareans, again, he quoted an incidence of 1.8% compared with those with 1 as 0.9%. Now, prior vaginal delivery, previous vaginal birth, particularly if they have had a previous VBAC, is a single best predictor of a successful VBAC, and almost 87 to 90% success rate for planned VBAC. The rate of rupture increases with each successive labor, but a prior vaginal delivery also increases the chances of a successful VBAC attempt. Now, indication for prior cesarean delivery. Now, if it is a breech presentation, there's almost a 91% success rate. Fetal distress, 84%. A prior dystocia is an important predictor of vaginal delivery after prior cesarean. Dystocia as the original indication has had a significantly lower success rate compared with those with other indications, that is 54% versus 67%. Now, fetal size, again, there is no proof that there is an increased fetal size which increases the risk of uterine rupture with VBAC. But the study by Zilop et al. Compared the outcomes in 2,750 women undergoing a trial of labor, of whom 1.1% had uterine rupture. And they said that the rate increases with the increasing fetal weight, 1% with less than 4 kilos, 1.6% with more than 4 kilos, and 2.4% with more than 4.25 kilos. Regarding multifetal gestation, there is no increased risk of uterine rupture with VBAC in twin pregnancies. Ford and Associates said 0.9% increase in rupture, and the successful vaginal delivery is almost 45%. And Cahill in 2005 and Warner in 2007 said the rupture rates were 0.7 to 1.1%, and the vaginal delivery rates were 75 to 85%. Maternal obesity again shows a decrease in the success of VBAC. Hibbard and colleagues said 85% with a normal BMI, 78% with 25 to 30 BMI. It goes down as the BMI increases, 70% with 30 to 40 and 61 with more than 40. Contraindications to TOLAC are previous uterine ruptures, previous high vertical, classical, T-shaped cesareans, 3 or more previous cesarean deliveries, contracted pelvis, all other obstetric and medical complications like malpresentations, APH, PIH, eclampsia, IUGRs, and medical disorders like hypertension, heart disease, inability to perform emergency cesareans due to insufficient staffing, and the woman herself refusing to have a VBAC. Now, to counsel the patient for VBAC, it should start as early as in the antenatal care checkup itself. So we need to discuss with the patient regarding the mode of delivery, and women should be offered information regarding the need for the first cesarean and implications it may have for future pregnancies and deliveries. So we have to identify at the first antenatal visit all women who have had a previous section or have a uterine scar. So a senior consultant should assess these women. Now, factors to note at booking visit include number and type of previous uterine scars, indications for prior cesareans, any puerperal complications, gestation at the time of prior cesarean sections, interconceptional intervals, other associated medical problems, anticipated family size, history of successful vaginal delivery, whether this was before or after the uterine scar. And the antenatal counseling, women should have a prior history of one uncomplicated cesarean in an otherwise uncomplicated pregnancy at term with no contraindications to vaginal birth. We should be able to discuss the option of planned VBAC and the alternative on an elective repeat section. The antenatal counseling for women with a prior cesarean should be documented in the notes. So a record keeping is definitely a must in all these patients. A final decision for mode of birth should be agreed upon between the woman and her obstetrician before the expected or the planned delivery date, probably as early as 36 weeks of gestation. What is the role of induction and augmentation of labor in VBAC? Now, it is shown that there is about 2 to 3 times increased risk of uterine rupture, around 1.5 times increased risk of cesarean section in induced labor compared with the spontaneous labor. Lydon and Rochelle and associates said induction of labor with prostaglandins for VBAC increased the uterine rupture risk more than 15 times compared with the elective repeat cesareans. Women who have had a previous section should be offered one-to-one care during labor in a unit where there is immediate access to cesarean section. Blood transfusion services or blood can be obtained with a reasonable amount of time. Facilities for continuous fetal heart monitoring, preferably electronic fetal monitoring, and specialist obstetrician, anesthetists, and pediatricians should be available round the clock. So a partogram is very important for the progress of labor. A partogram, which in addition to monitoring progress of labor, it also enables effective monitoring of maternal parameters like blood pressure and pulse rate. And the duration of labor should be closely monitored with special reference to alert and action line on the partogram. And prolongation of the labor is an important sign of for dystocia. Analgesia, again, epidural analgesia is not a contraindication for TOLAC, and adequate pain relief may encourage women to choose TOLAC. Effective regional analgesia should not be expected to mask the signs and symptoms of uterine rupture. Now, regarding the delivery, second stage should not exceed 2 hours, 1 hour to allow passive descent, but no more than 1 hour for active pushing. Assisted delivery ideally should be performed by an experienced consultant. And in the operating, they mentioned that it should be done in the operating theater, but most of us do conduct it in the labor room. And we have to have a provision for an immediate cesarean section. Excessive vaginal bleeding or signs of hypovolemia are potential signs of uterine rupture and should prompt complete evaluation of the genital tract. Now, the scar integrity need not be tested as a routine. Now, uterine rupture is the most dreaded complication of TOLAC. The risk of rupture is around 0.5% with the TOLAC. Maternal and fetal morbidity of rupture is around 10 to 25%. And in rupture, 1.5 per 10,000 risk of perinatal death and 4.8% per 10,000 risk of hysterectomy. Early diagnosis of uterine scar rupture followed by expeditious laparotomy and resuscitation essential to reduce the associated morbidity and mortality and infants.
Dr. Suma, excuse me, please. So
Yeah.
the time, maybe about 1 minute more, please.
Yeah, another few minutes. Come to the next slide. So clinical features associated with uterine scar rupture are abdominal CTGs, severe abdominal pain, acute onset of scar tenderness, abdominal vaginal bleeding, hematuria, cessation of previous efficient uterine activity, maternal tachycardia, hypotension and fainting, loss of station of the presenting part and change in the abdominal contour, and inability to pick up the fetal heart. So planning and conducting of VRCA should be conducted after 39 weeks of gestation. Now, these are some of the ACOG practice bulletin in summary. I think I don't need to go ahead with this. To conclude, planned VBAC is clinically a safe choice for the majority of the women with a single previous seizure. Such a strategy will at least limit any escalation of cesarean delivery rate and maternal morbidity associated with multiple sections. So trials in life are not meant to make us fail, but to see how far we can fly. So with these few words, I welcome you all to the International Labour Congress Conference, which will be held in August 2025 in our hospital. And I will invite all of you to come to this program.
Thank you very much, Dr. Suma. I think that was a very elaborate and well-presented facts about previous cesarean. Two quick questions. So the two people in the audience, they have a question to ask. Is there a role of ultrasound to assess the scar thickness? I think you said there is no point.
Radhika,
no, there is no role.
Radhika, we can ask Madam to answer in the chat box because we have to.
I think that's a great idea.
Yeah.
So,
and one more point I forgot is to, if suppose a patient has had an IUD with previous section, one of the drugs, good drugs used is mifepristone, because yesterday we had a discussion regarding this. So mifepristone can be given 200 milligrams, so 8 doses can be given, and they have a good response to mifepristone, or 600 milligrams twice daily.
Yeah, thank you very much. So there is an important question in the chat box. I would request you to kindly respond to the same. So we go on to the next speaker, please. There is a time constraint. Thank you very much. So can we have the introduction slides for the next speaker, please?
Kavita Chinmayi's slide.
So we are very happy to welcome Dr. Chinmayi Ratha. So I think, again, she's one person who really does not need a introduction. We know her all. So Dr. Chinmayi is
it's okay, can we move on to
so it is completely filled. So obviously there is a lot of hard work that has gone into getting all this on the slide here. Warm welcome to you, Chinmayi. We wish to listen to you. Yeah.
Thank you.
Kavita, you can stop sharing.
Share my screen, please.
Yeah, Kavita, stop sharing, please. Yeah. We have taken this talk. I know that this is a little out of the way and it's a clinical topic, but this is something which I've always felt should have been done much earlier. And Chinmayi is a very, very apt person on talk on that, because we are part of the language cell of FOGSI, where we're thinking of like changing little the nomenclature as far as labor is concerned. And Chinmayi has done lots of work on that. So that's why I thought this would be a good topic to talk. A little light, I would say humor in the middle somewhere. So we also talk about the lighter side of labor also. So that's the way we chose this.
Thank you. Thank you so much, Radhika ma'am. Thank you, Charmila ma'am, for the invitation. And I think it's a very, very intensive course on labor. And like she said, my topic is a little offbeat, and I really don't know how useful this will be, because it's all about nomenclature. A lot of obstetricians who deliver babies day in and day out and who can manage labor in so many ways, that, they have done this for centuries actually, and they have a lot of confidence in how they do things. So it really doesn't matter to them what you call labor. And that's what Shakespeare said once when he said, "What is in a name? If you don't call a rose, it will still smell as sweet as it is, and it will still be as beautiful as it is." So it was a very Shakespearean idea that there is nothing in a name. You can call anything with anybody. But in science, we like calling people with the correct name, and nomenclature is a very important part because name is a kind of identity and is a kind of identification of the situation we are dealing with. So when it comes to labor, even in labor, language is a very powerful tool, and it's a medium not only to influence, persuade, or assert matters, it also helps in creating a framework in which our attitudes, shape, and practice ultimately takes place. So we should use language which is inclusive and avoid stigma. And this holds true for labor also, for any aspect in science also. So it's important to review the contemporary language use and make recommendations for clinical practice. So the Royal College of Obstetrics and Gynecology regularly publishes what is called a language guide. And therefore, they have certainly given some criteria where you need to look at some words and consider them appropriate versus inappropriate. For example, in this table that you see here, certain things like fetal demise, spontaneous abortion have been called as miscarriage. So if you come to the part of pregnancy, while you manage the pregnancy, you care for the pregnancy. So there are very subtle changes in the words, but they change the perspective with which you look at pregnancy. So you don't really always need to manage a pregnancy, you can only care for the pregnancy. Similarly, instead of saying geriatric mother or an older person, you say a woman who is over this age and having a baby. That makes it a little non-judgmental overall. So this is about the entire OBG paraphernalia related to pregnancy and childbirth, where RCOG has suggested these words. As Charmila Madam very rightly said, our past president FOGSI, Dr. Jaideep Tank, had started this intervention of creating a cell for language and imagery. And she was also part of the cell, and I was also part of that cell. And there were certain terms in particular relation to labor which were reviewed, and words like failure to progress was recommended to be replaced, and instead of saying failure to progress, the recommended word was delayed progress or non-progress, because the term failure itself is a bit judgmental and puts the blame on the parturient or the woman in labor. Similarly, poor maternal effort or failure to push needs to be replaced by maternal exhaustion, because it's not a failure to push from the maternal side, but it is a challenge that she faces in labor, not the lack of effort, but at some point the energy wanes off. So we use maternal exhaustion instead of failure to push. Similarly, the word fetal distress by itself is a very vague word, and it leaves a lot of scope for questioning. And therefore, it is recommended that you specify the cause of intervention in labor, which is either a deceleration on the CTG or meconium stain amniotic fluid, something where you feel that this is specifically the reason why you suspect the fetus is not in a absolutely great state to continue the labor, so that your intervention becomes a justifiable act and that condition is justified. Similarly, the obstetric codes was something Dr. Charmila had worked on and proposed, that we should have obstetric codes for particular emergencies. And the two codes that can be directly related to the process of labor would be code 77, that would recommend a fetal emergency which needs an urgent delivery. You always have a code blue where you always call for a maternal emergency. But if there is a fetal emergency where the fetus needs to be resuscitated, then the decision to delivery interval should be as minimum as possible, but at the same time, you need a person who can resuscitate that fetus in the code emergency team. So the code 77 will alert the neonatologist to come in there, because there will be a need for a fetal resuscitation. Similarly, code omega can be activated whenever there is an obstetric hemorrhage or a massive transfusion protocol that needs to be initiated and implemented rapidly. So in terms of all the codes, these two would make specific relevance in the process of labor. The WHO has given a labor care guide and a user's manual where
many things have been redefined in terms of the way that we traditionally looked at labor. And one of the first things that they have suggested is redefining this active phase of labor in the first stage and the latent phase in the first stage. So the latent phase has now become characterized as the time from the beginning of painful uterine contractions to the progression of dilatation up to 5 centimeters, whatever the effacement. And the active stage of labor is after the 5 centimeters dilatation to full dilatation with the presence of uterine contractions and progressive effacement. So up to 5 centimeters is considered as the latent phase, and 5 centimeters to full dilatation is now the active phase of labor. Also, they have recommended, instead of the traditional partogram that was used with the action line and the alert line, they have recommended another method of documenting labor, which is divided into 7 sections. The 7th section is the shared decision making. You can see the 6 sections on the screen here. And as you can see, identifying information and labor characteristics at admission, supportive care, care of the baby, care of the woman, labor progress, medication, and shared decision making are all in one sheet. But the way it is represented is a little different from the traditional thing. So in labor monitoring, they have put an approach of assess, record, check the threshold. That means the alert line now becomes that check the reference threshold, and plan, which is the intervention. So assess, record, check, and plan. ARCP is what they recommend there. And the nomenclature has been very clearly defined in the labor care guide as to what to allocate in each shape. So suppose you want to put in ruptured membranes. If you know yes or no, you can put Y or N. If you do not know, then you put U. So where do you need to put yes, no, where you need to put woman declines, where is supine, where is mobile, everything has been put into very, very short, abbreviations, and that can be clearly demarcated on that sheet which I showed you under all these sections. So you can see section 1 to section 7. There are, different applications that can be done there. This is the WHO Labor Care Guide, and it is freely downloadable on the internet. And you can always take that there. Otherwise, I can send the link after this film. So this is just to show you how exactly that is marked there. So whatever is the alert, if you have put something like an alert there and she said no companion, then you have N and you've alerted it. So you know that she had asked for no companion. She has not accepted pain relief. So there is N, and then there is a, sort of this position. She was mobile earlier, now she is supine. So that is an alert for you. So this way you can make it. And I'll just run it show again. So the nomenclature to complete the labor care guide has been very, very clearly defined in non-numerical observations also, making it objective by the use of abbreviations. So this is how the sections can be complete. And when it is complete, it is easy for the clinician to take a look at it and have a clear guide. So the final, sheet might look like this, where a lot of detailing has been done by the midwife clearly. When did she ask for a labor companion, how far she was in pain, what was the way she went forward. And according to the WHO, this is not only going to fulfill the criteria for respectful maternity care, it's also going to be effective for communication between healthcare workers and allow timely alerts and interventions with a sturdy documentation and a positive birth experience. Then the other aspect in labor where nomenclature seems to be changing is the classification of the cardiotocograph or the CTG. I will thank Mitra Madam for bringing my attention to this particular document, because I talked to her since she was the chairperson of the Practical Obstetrics Committee to find out what else is changing. And she reminded me that, look into that CTG. And this is a very interesting read because it has been published in 2024. It's a document by Edwin Chandraharan, and they have done a very paradigm shift from the classical CTG classification of, normal, suspicious, and pathological to a new checklist, which helps in recognizing the types of fetal hypoxia and also to assess whether this fetus is good enough to go into labor, and in labor, whether this needs any kind of intervention. So the decelerations, which we were traditionally calling as early decelerations, and the definition was 15 beats per minute, 15 seconds, has now changed to 30 beats per minute within 30 seconds. And whatever was early is now known as a quickly. So early has become quickly, like you said, you'll laugh at the change in words, but the definition has also changed from 15 to 15 is now 30 to 30. And as always, this represents that, head compression kind of problems, whereas the late decelerations are now the decelerations which stay even after the recovery of the contractions, and they are now termed as tardy decelerations. And tardy decelerations do represent a degree of uteroplacental insufficiency, and the pathophysiology is kind of the same what it was earlier, but the names have changed from early to quickly, and from late to tardy. But what is interesting now is a redefinition of uteroplacental insufficiency into something called a relative uteroplacental insufficiency. And some of these tardy decelerations, which are wide and deep with regular uterine activity, do represent, some subclinical hypoxia, and therefore your threshold to intervention will increase when you see this. In addition to that, there is a recognition of something called a zigzag pattern. If you remember, we used to have something called saltatory pattern written in the previous CTGs. That is the zigzag pattern, and that zigzag pattern of abrupt changes in the fetal heart variability of more than 25 beats per minute also indicates a rapidly evolving hypoxic stress. And if you see a zigzag pattern that lasts for more than 1 minute, there is some need for improving fetal hyperoxygenation, and that should be done immediately. Sometimes there could be an increase in the baseline without much change in that variability with ongoing myometrial irritability. And this kind of a picture could be because of some kind of fetal infection. So these are signs of fetal infection, Sophie chorioamnionitis. And similarly, you could have some kind of, zigzag pattern in between without cycling. So this is a new checklist that they have suggested to, classify the CTG, and that is called the caution checklist. Cycling is absent, acceleration absent, unstable baseline, tardy recovery, irritability of the uterus, obvious history, and non-hypoxic features. These are the alert lines which we should remember and, try and intervene if the fetus is in distress here. So these are again given in the same document that I showed you, and these will help in recognizing features of chronic hypoxia and pre-existing fetal compromise. So the need to redefine this was to find the pathophysiological characteristics of a subtype of hypoxic stress that arises at the onset of uterine activity. So in labor, that is the one which you are looking for, which is the relative uteroplacental insufficiency of labor. So instead of having very non-scientific timelines, very or subjective interventions here, interpretations, this will lead to a more objective interpretation of the CTG. So whatever we see today will become old tomorrow. So all these names which I have told you today will probably not stand the test of time, and something will get redefined, because not that things are really wrong the way we are doing it today, but the way we understand the pathophysiology changes. And once we understand the pathophysiology better, then we try to redefine things. But what will never change is calling people by the correct name is always the correct thing to do. So if you go by the Shakespearean idea of how does it matter what's in a name, we can call a rose or anything else, it'll still smell as sweet. That is not correct, because unless you use the right term in science, we are always wrong. Thank you very much for a patient hearing.
Thank you very much, Chinmay. That was a, what should I say, thought-provoking talk. I think we can have a good debate on this.
Can do such talks, I would say.
I was in a spot, ma'am. I was in a total spot.
Really stimulated the mind. Thank you very much.
But thank you for giving me the topic, because even I had to think a lot about it. Thank you so much.
My mind is full of questions.
Thank you, Mitra ma'am, for your inputs.
Thank you. Thank you for stimulating us immensely. And over to you, Charmila, and the rest of the team. Thank you very much for inviting me here. I thoroughly enjoyed these sessions, and I think these were, I'm sure the audience is full of, appreciations I can see in the chat box. So thank you very much.
Thank
you all again.
Yeah, thank you, Radhika. Reshmi?
Thank you so much, Dr. Radhika, madam. Thank you for chairing the session. Now we are moving towards our panel discussion, very interesting panel discussion on intrapartum surveillance. And the moderators for this most awaited panel discussion are Dr. Mitra Saxena Madam and Dr. Surekha Tade Madam. And the panelists are Dr. Renju, Dr. Lavanya, Dr. Swati Rathore, and Dr. Vijay Lakshmi Sabha. I would like to introduce the moderators to the House. Professor Dr. Surekha Tade, as we all know, she is the chairperson of Clinical Research Committee, and she is the professor and IVF in charge at Dr. Punjab Rao Deshmukh Medical College, Amravati. Welcome, madam. Dr. Mitra Saxena, madam, we all know for her huge work as chairperson of Practical Obstetrics Committee of FOGSI from 2021 and 2024. She is a great guru and a great guide, and known for her huge work in practical obstetrics. Welcome, madam. I would like to introduce the panelists to the House, Dr. R. Renju. She is a consultant, Arun Hospital, Dharmapuram, and she is a faculty in national state conferences and national conferences. At present, she is Joint Secretary of IRODE, OBGYN Society. Dr. S. Lavanya, Madam is trained in infertility at Asha Hospital, Coimbatore, and she is working as assistant professor in RSRM Maternity Hospital, Stanley Medical College, Chennai. Welcome, madam. Dr. Swati Rathore, madam is professor and HOD, Department of OBGYN Christian Medical College, Vellore, and at present she is secretary of Vellore Christian Obstetrics and Gynecological Society. Welcome. And Dr. Vijay Lakshmi Sabha, madam is medical director at Mangalam Hospital, and she is secretary of Kanchipuram OBGYN Society and state committee member of IMA, Tambaram. Welcome, madam. Over to the moderators.
All the panelists are unmuted.
Thank you, Dr. Rashmi, for all the introduction. And here we come again. The do duni char. Once again.
Sarika, 1 second. We'll just check whether the panelists are unmuted.
Yeah.
Vijay Lakshmi Sabha, can you unmute yourself? No. Please make her as a co-host. Shreya, please make Dr. Vijay Lakshmi as a co-host. Dr. Renju, can you unmute yourself?
Yes, ma'am.
Charmila, is the screen visible?
Yes, ma'am, it's visible, ma'am.
Okay.
Lavanya, can you unmute yourself? Yeah.
Yes, ma'am. Already.
And who's the fourth person? Swati has joined?
Swati. Yes, ma'am. Yes.
Okay.
She's traveling.
So Vijay Lakshmi has been unmuted, no? Vijay Lakshmi?
Yeah, yes, madam.
Okay,
Yes.
okay. Thank you. So Surekha and Mitra, madam, please continue. Sorry.
Okay. Yeah, thank you so much. At the outset, I would like to thank Dr. We would like to thank our ICOG chairperson, Dr. Parag Biniwale, and of course, Charmila, for this very great learning that you are providing for us and the opportunity. And I must thank Chinmay. I think she has made our job so easy by the nomenclature. And we were just discussing yesterday that this new nomenclature has come up, and we are yet to, in our Indian settings, in our clinical settings, we are not yet started using these words quickly, tardy, cycling, and we were just thinking, we were discussing whether we should bring it in our panel or not. And here we are, Chinmay has already created that platform, and we are now, worrying whether we should have those discussions or, but I think we have the case-based discussion where we can talk about the clinical settings and the CTG and how to look at both together. So over to you, Dr. Mitra.
So thank you so much, Surekha and Chinmay, Dr. Parag, etc., everybody. And it is a great learning indeed. So basically, we decided that we will restrict ourselves to CTG and understanding of CTG, which we know is a tool for fetal surveillance. But as you will look at the image, that there is so much of confusion regarding even understanding the CTG. Many people in our country are still not using it, and then those who are using it are often confused. But we have to understand that CTG is now very well analyzed, and the paper that Chinmay has flashed, that is really simplified the understanding of how the fetal physiology is working. So in our panel today, we'll try and focus on graphs, cases, and management, and also talk about understanding the changes that are brought about in the baby. We have to understand that labor is a stressful, hypoxic journey for the baby. What we need is to provide reassurance to know that the baby who starts the journey is adequately oxygenated at the outset, and to avoid unnecessary obstetric interventions. And also, whenever there is a stress, we should be smart enough to identify when the baby is not oxygenated or decompensating, so that we do not let any injury happen. So it's a very big balancing act, and I'm sure if we understand the physiology of why and how these changes are happening, we'll be able to make up our mind about decreasing the interventions and also not getting poorer outcomes. So over to you, Surekha, to take the basics.
Yeah, we do know the basics. We're talking of the fetal heart rate. We are talking of the fetal movements as indicated here, and of course the uterine contents. So when you're talking of the cardiotocograph, it is the fetal part and the uterine part, both are there in the same graph, and that is what we usually interpret when we are talking of our CTG. Next slide, please. And of course, it's very important to know these boxes very well. One box is 10 beats, 2 is 20, and we really need to know the horizontal and the vertical, the timeline as well. So these are very important settings which we need to understand, and what kind of paper you are using, what is the speed of our CTG, the paper settings. These are all very, very important. These are the recommended one. The FHR display should be from 50 to 210. This is the nice guideline 200 to 17, but we do have 18 guideline as well now, which Dr. Chinmay was talking about. The paper settings are very, very important. The display is very, very important, so that we can very well identify what's happening in the baby, and we can take, interpret very well. Interpretation is very important, because if we do not interpret well, there will be a lot of interventions which we do not actually want. We do want interventions where is deoxygenation is there. However, we need to be very careful how we are interpreting. So this is the interpretation of the CTG. We do know the acronym that Dr. C. Bravado. DR is defining the risk existing in the patient. C is the contractions. BR is the baseline rate. V is the variability. A, accelerations. D, decelerations. And O, what is overall, what is our impression about the case. So next slide. So first, so we are going to have a case-based discussion, and we'll be very focused about interpretation of the CTG and the case and the management. So we will not deviate too much. Okay, we'll just focus on how to interpret. So Dr. Renju, this is a second gravida, previous one delivery, previous vaginal birth, and 30-year-old, and she is 41 plus 2 weeks of gestation. She came with mild pain in the abdomen, uterus is irritable, or mild pain is there, mild activity is there. This is the CTG. How do you interpret this CTG, please? Read the CTG first.
Yes, ma'am. CTG is a graphical representation of what is happening inside the baby. Fetal well-being is being assessed. So I'm going to interpret the CTG right now with Dr. C. Bravado. DR defined risks. It's a high risk. Why? Because post-date 41 plus 2 weeks. So my monitoring will be continuous. See, contractions, are they present? No, they aren't. It is less than 5 Montevideo units, so the contractions aren't present. The baseline rate is around 130 beats per minute, which shows that the CNS is all right and the vagal nerve stimulation is also all right. The next one is variability, beat to beat variability. Some are 5, some are 10. So beat to beat variability is adequate, moderate, and that means the peripheral nervous system, both the sympathetic and the parasympathetic, are working in tandem with one another. Regarding the accelerations, there are 1, 2, 3, around 4 accelerations. Adequate accelerations actually, more than 15 beats lasting for more than 15 seconds. Are there any decelerations? No, there aren't. So according to me, if I interpret the CTG, everything comes under the white category. And so it is a normal CTG.
Yeah. So next slide here. So you very rightly talked about the baseline. It's a reactive. There are no accelerations are there adequate, no deceleration. So we actually would be reassuring this patient, isn't it? But what about she is a high risk, as you said, 41 plus 2 weeks of gestation. So how would you manage? Would you like to go in for a color Doppler, or would you like to augment, or what would be your labor management for this patient?
Because she has already crossed the expected date of delivery, ma'am, I would like to induce her. And for that, I will do a vaginal examination and I would assess the Bishop score, ma'am. If adequate, I'll induce. But before that,
Would you like to
I'll
know about, would you like to know about what is the Likert status, how would be the color Doppler or anything else by physical profile, or do you directly want to go and augment this patient? More
No, ma'am, I
information is needed or not?
I don't think. I think it's a reactive NST. So, I mean, what Renju says seems
Yeah.
to be quite okay. So it's a
Of
second
course, you
traveler normal.
can the amount of Likert, yeah, you would definitely like to know, I think, and it's a reactive CTG. That is correct, But would you really like to go and augment, or would you just would like to sweep, stretch, and wait? What is your idea?
No, ma'am, I would want to deliver her anyway. Right now, it is reactive. So it says that the fetus can withstand the hypoxic stress of labor. So
Sure.
I will go for delivery, ma'am. I would do an
That-
ultrasound and I will do a Doppler also.
Okay.
Chalo, let's not, it's okay.
Yeah.
Idea
go
is
ahead.
that we have to be careful during the progress of labor. At the outset, right now, baby is fit to take the journey. And of course, the continued monitoring has to be not on continuous CTG, but yes, we can do intermittent. Can we do next one? Okay. So, Dr. Lavanya, I invite you to look at the CTG. This is a 30-year-old, 35 weeks of gestation, admitted in spontaneous labor. She's fully dilated on examination. The head is only 0 by 5th palpable, means engaged, in LOA position with minimal caput and no molding. She has made good progress from 3 centimeter to full dilatation in 3 hours. She has been pushing for 1 hour. You are asked to assess the CTG. Dr. Lavanya, over to you.
Yes, ma'am. Thanks for the opportunity, ma'am. And that's what she is actually defining the risk. She belongs to high risk because she's a preterm, she's in preterm, and she's already laboring, and so she belongs to high risk. Coming to the contractions, she has adequate contractions around 3 per 10 minutes, and it is of good intensity and good frequency. Already she's fully dilated, and baseline heart rate is good actually. It is around 160 to 170, which is in the non-reassuring range, but still baseline heart rate is okay. Variability is around 5. That is also fine. There are no accelerations and there are repetitive decelerations. Some few are late and few are variable with concerning features as well with biphasic pattern. So this is the general picture, and the overall picture is it is a pathological CTG, but still the baby is trying to compensate and come to the baseline, and it's trying to recover. So still it is compensated, but of course the CTG is little alarming to look at. But of course, when a second stage CTG is there, it is always confusing and it is very difficult to interpret because we will be generally hesitating, and I think we should not hesitate to take a shared opinion on this as well, because second stage CTG is difficult to interpret. But having said that, she's fully dilated and the head is not palpable per abdomen. She's almost CPD is ruled out, no molding. So I think she's all set to deliver.
Yeah. So I think Dr. Lavanya, you have read the CTG very nicely, and also you've assessed the baby very nicely. What I want to just say two things. One thing is, although these decelerations, like we were previously looking at early deceleration, late deceleration, biphasic, that nomenclature is not important right now. As already Dr. Chinmay has pointed out, what is now being observed is that this is a stress. The baby is responding, this contraction is a stress. The baby is responding by a decrease in the heart rate. So the load on myocardium is less, but the heart rate is recovering. So when the heart rate is recovering, it's good. So basically, the baby is compensating. So right now, what we have to do is expedite the delivery. So important thing is to see the baseline, to see the variability in the baseline. That will tell us whether the baby is compensating. And if the baby is compensating already, we are close to delivering the patient. So in this case, there is, because of second stage, there is subacute hypoxia, but we are very close to delivering. We can ask her not to bear down actively. Like, I'm not going to ask these questions, Sureka, because I just want to finish it fast. What I want to just mention is that pushing can produce this kind of feature. So if there is any oxytocin, it has to be stopped. And you can ask the patient to bear down on an open glottis. That will oxygenate the baby and expedite the delivery. So basically, going back to this image, we should not be afraid as long as this baseline is right. And you very rightly said that this looks scary, but according to the new nomenclature and the latest recommendations, we have to bother about the baseline. If there is, and here again, the tachycardia, which you have very rightly pointed out, does not seem to be a sign of distress because it's 35 weeker. So we have to look at the gestational age, and in that perspective, look at the heart rate. If this was a term baby and this tachycardia, then it would be, we have to, consider that there could be some kind of decompensation. So I think would Dr. Lavanya, if
Yes,
you were
ma'am.
to deliver, what would you do? Would you use a vacuum or a forceps? It's a preterm.
Preterm, I would like to use a forceps now because again, preterm is a challenge.
Yeah.
So given the choice, I would like to use a forceps here.
Yeah, so very good. I think that's very nice. You have interpreted the CTG very well. Over to you, Dr. Sureka.
Dr. Swati, here is your case
Yes.
for you, and
Yes.
definitely please have a look at the CTG, and we would just like you to just read the CTG first, and then we'll let you know about the case.
Yeah, so there is a baseline tachycardia, reactive trace, accelerations are there, there are no decelerations, only the fetal tachycardia is there. So the baseline, it is high, so 160, 180, 160 to 180. Contractions are not there, so it means she is not in labor. Looks like
Yeah, so
fetal
we'll give you the
tachycardia is there.
case details
Okay.
now. She's a 28-year-old, second gravida, previous vaginal birth, 38 weeker. She's complaining of fever since 2 days. Please just click on the Dr. Mitra. And she's also having diminished fetal movement since a day. As you rightly pointed out, the CTG is having a tachycardia, but variability is there, accelerations are there. How would you like to proceed with this patient who has fever?
Yeah. So the most common reason for the fever in a pregnant lady it can be the leaking. So first we have to rule out, as she has a fever is there since 2 days. So first thing is the chorioamnionitis is one of the reasons. Immediate delivery is the antibiotic, antipyretic, hydration, and delivery. These are the 4 things which we have to see. As she has a decreased fetal movement, even if the leaking is not there, you have to deliver her early.
Okay, so there could be other causes of fever as well. Many a times it may not be leaking, it may not be chorioamnionitis. So let's look at the other causes also. Evaluate the patient holistically. What are the other causes? You could investigate the fever. There could be anything, it could be a simple fever, viral. It could be, so let's not have that kind of vision. It could be anything. It could be chorioamnionitis as well. So let's let's do a perspective examination. Let us find out if there's vaginitis. You could send a vaginal swab, urine culture. These are all investigations which you would like to look at, and we would like to treat the fever first, treat the cause of the fever. Definitely see, we are not want to treat the CTG. What we want to give the message is the CTG is having tachycardia, fine, but we'll have to look holistically at the patient. What is her cause? We need to treat that cause, and whatever the cause is, we would like to manage accordingly. And let us not be in a haste to deliver a patient who is having fever. Let us settle her down first. If she needs an antibiotic or according to the cause of fever, we'll manage her, and then maybe a repeat CTG will find that once the fever settles, maybe the CTG also, the tachycardia will also settle down. So the take-home message is, instead of treating the CTG, we have to treat the patient and find out what is wrong with the patient and then treat accordingly.
Yeah, very nice. So just one thing I will say, that Dr. Swati has very nicely picked up the tachycardia, and that is corroborated with the case presentation. And here we can see that this is very straight line, baseline, and then here is reactivity. So we have to see cyclicity. With tachycardia, baby is fine, but so as Sureka has already mentioned. So now I will go on to Dr. Vijay Lakshmi. Please read this CTG. Sorry that the numbers are not very clearly visible, but please have a look.
Yes, madam.
Overall, eyeball.
Okay. This shows an where there is a baseline heart rate is quite high, more than I'm sure it is more than 160 and above, and showing some varied decreased variabilities decreased, and also few decelerations are seen here and there, and the contractions are very minimal. Uterine contractions are seen. So, and the FH is around 150 to 160 heart rate. It's been seen in this patient. So, what is the cause of her tachycardia, and
Yeah.
what is the cause of her decreased variabilities, and what is the cause of her minor changes of decelerations?
So I will give you the case profile now. So this is a Gravida 3 para 1 L1 previous normal delivery, and she's like you saw the tachycardia. So we have to keep two things in mind. Is it premature or is there is infection? So here both the things are there. She's a 32-weeker with PROM, with fever, foul smelling vaginal discharge, and temperature 101 degree, and tachycardia, markedly reduced variability with fuel. So you picked up all the points very correctly. So Vijay Lakshmi, quickly just say the cardinal steps. We will not go into the details.
Yeah, here one is a preterm. Second one is the maternal tachycardia is there because of fever. So along with the temperature, my fetal also will have tachycardia, but that reduced variabilities and decelerations are the important point to tell that the baby is in distress. What is the cause of distress? We can think about is foul smelling and vaginal discharge, which has been marked there. So look out for a vaginal examination and see what the give her the culture, and it is a case and see what is the findings, PV findings. And because she's 32 weeks and foul smelling, she's in cases of a severe chorioamnitis, which has affected the baby also. So I don't think so. Seeing the Bishop score, if it is progressive and she's delivering in the terms of more than 5 centimeters, you can go in for and do a normal delivery. But if there is no if there is no Bishop score is very poor, it's no use of waiting. But we have to take her up immediately and do a cesarean section to prevent infection for the baby also. It's already spread to the baby. And
So
we have to
basically,
do this under IV antibiotics, broad spectrum antibiotics, hydration of the mother, everything has to be done.
So
Even at
basically,
preterm,
the two things that were very important for the management is that there is no role of conservative, even if it's prompt, because we have already picked up chorioamnionitis. So the baby is at danger because of chorioamnionitis. But as Dr. Sureka said, that the mother's fever also has to be brought down. So you very rightly said that broad spectrum antibiotics and stabilizing the mother and ensuring that she delivers. We don't have to be in a hurry to do a cesarean section. We can always induce her and deliver her. But yes, we have to remember this entity of, suggestive of fetal inflammation, because the fetal inflammation is also a reason for HIE. So we have to weigh the mode of delivery, cesarean, oblique, vaginal. All we need to do is we have to expedite the delivery. So whatever is successful, sometimes preterm prompt, she will deliver provided we induce her properly and monitor her. I think that's fine. Let's go on to the next question, Dr. Sureka.
Yeah. So, Dr. Renju, we have a CTG for you, not a very big one. It's a small graph we are showing you, and hope you can,
overall impression.
Yeah, overall, just eyeballing.
Yes, ma'am. So the baseline heart rate is 170. Tachycardia, it is a red sign, ma'am. So directly it becomes a pathological CTG, number one. The beat to beat variability is not there. And there are no accelerations. There is a small deceleration. And the second one is a very big deceleration. It is coming back to normal baseline, but still there is no shouldering. There is some amber sign. Overall, it is a pathological CTG, ma'am.
Yeah. So this is the case. Can you just click on? Yeah. This is a sixth gravida, 4 abortions, and she's a 36-year-old, 7 weeks, APLA positive with on low molecular weight heparin. She took 40 milligram at 9 a.m. in the morning, and she came at 7 p.m. with pain since 2 p.m. And this is the admission CTG. what would be your plan? See, you rightly said there is tachycardia, reduced variability, there are the decelerations are there, no much activity. How would you plan? What is the risk of bleeding? How would you now manage overall this patient?
Immediate delivery is needed, ma'am. Will I plan for a normal delivery? Maybe if the Bishop score is very good, I will try. But still, this is what, as Chinmay madam said, relative uteroplastical insufficiency of labor will be there because the trophoblastic function is severely affected because of the APLA. So maybe I'll directly plan for a cesarean section straight away. But she has had her low molecular weight heparin, ma'am. 24 hours ideally, only after that I'll have to plan. But if it is a low dose of low molecular weight heparin, I can try for a
So with
delivery.
this CTG, would you like to wait for 24 hours or would you
No,
like
no,
to
no,
arrange
ma'am.
for some fresh
Immediate
frozen
delivery.
plasma? And
Yes, ma'am.
yeah.
The coagulation cascade will not be good because of this low molecular weight heparin. So I'll keep all the products ready, the platelets, the blood, and the fresh frozen plasma, everything ready, and then I'll go for a cesarean section. I would prefer a general anesthesia, but if my anesthetist is confident, maybe regional anesthesia also, ma'am.
Yeah. So as you can as you rightly said, see, this is the good variability is not there, and this kind of hypoxic stress is already existing in this patient. So we really need to look at these, evidences of evolving hypoxia, as rightly said, in this patient is already there, and once we identify these, the LMWH, we should not be worried about too much. We can do the INR, but if we arrange the fresh frozen plasma, we have seen a lot of experiences there with LMWH. 6 hours are also enough. May not wait for 24 hours for the effect to wane over. And this kind of patient definitely needs an intervention, and we can keep everything ready and deliver this patient. You can have the next slide, Dr. Mitra. Where
I just wanted to mention one thing.
Yeah.
I will just like to show that this tachycardia is there with deceleration. So this tachycardia in a 37 weeker is very significant. It shows that there is adrenaline response of the baby to the hypoxia. So tachycardia in a baby after deceleration has to be seen because this is a compensation by the baby, and this can actually, deteriorate very fast. So I think you've already mentioned all that.
Yeah. Next slide.
Okay. Yes.
Yeah.
Yes.
These are the traces actually which warrant delivery. Deceleration without baseline variability, as rightly said here, the variability is very much declining, and baseline tachycardia also rightly said in this term patient is one which warrants delivery, and prolonged deceleration we didn't find in this patient, neither sinusoidal pattern, but two very important red flag signs are there, the tachycardia and the drop in the variability. So these are very important things to be noted down which warrant delivery in this patient. Next
Okay,
slide,
so
please, Dr. Mitra.
Dr. Lavanya, I invite you to look at this graph.
The graph shows that the contractions are minimal and not of very good intensity. Baseline heart rate is around 130 to 140. The images are not very clear, but 130 to 140 with a variability of around, say, 5 to 15 beats. So baseline heart rate and variability is good. And coming to accelerations, there are no much accelerations noted, but 2 to 3 decelerations are noted, and it takes lesser time for recovery. It comes back to baseline, so still the baby is in a compensated stage. But in the second half of the CTG or fag end of the CTG, there appears to be a bradycardia, which is little prolonged for more than 2 to 3 minutes, but I'm not sure whether there is a loss of contact there or is it real a bradycardia, because that has to be differentiated, because a good baseline and good variability and sudden falling is not very much expected out of a normal baby. So we have to exactly think whether it is a loss of contact or a change in position, or is it a true bradycardia.
Very nice. That was very aptly seen that we should not be extremely, jumpy. If we see that there is bradycardia, it could be loss of contact also. We have to look at the prior, fetal assessment by the previous, within seconds. But yes, of course, it is acute hypoxia. This could happen. So now here, there is progressive decreasing baseline with prolonged deceleration, and it indicates acute hypoxia. So here the patient was on syntocinon. So what would you do?
Yeah.
If you see this, and of course, this is alarming when there is deceleration for a longer time, it's going to cause hypoxia.
Yeah, you
So
should
what
go
would be
back instead
our...
of revealing all the management.
Sorry.
So we
Okay.
just wanted to highlight this patient that she
Yeah.
was induced with oxytocin, you know, and we can have this kind of bradycardia or prolonged deceleration with oxytocin. Lavanya, what do you say?
It's time
She's
for
on
intrapartum.
oxytocin. Yeah.
It's time for intrapartum resuscitation right now. First, stop the oxytocin drip. That's the first and foremost thing which we have to do. And put her in left lateral position. Try to give her fluids and give her good around 10 liters of oxygen. And these might help the baby to compensate and come back to normalcy once the contractions are relieved. And then we already she's belonging to a high risk this thing because she's already crossed EDD. So we expect all placental insufficiency, oligohydramnias, all that stuff. So I think it's time for her to deliver. She her Bishop score, and if it is not favorable, I think we should go ahead with the planned delivery, probably cesarean section.
So
Yeah, I
basically,
think
she was induced with oxytocin, but once we stopped the oxytocin, she progressed normally. The baby was compensated and she actually delivered vaginally. So in acute hypoxia, we have to remember if in active labor there's acute hypoxia, which is seen by a prolonged bradycardia, then it could be because of irreversible causes, cord prolapse, retroplacental bleed, scarnescence, and reversible causes like acute hypotension, especially if somebody is using epidural. There, the maternal hypotension is very common, and that could be one of the reasons that the baby will have bradycardia and uterine hyperstimulation, which was in this case, and it was rightly, rectified. If the deceleration does not improve after doing tachylysis, stopping the oxytocin, resuscitative, would you like to tell us quickly about this 3, 6, 9, 10, 9, 12, 15 rule?
Yes, ma'am. 3, 6, 9, and 12 is immediately call for help and then proceed with intrauterine resuscitation. Try to deliver the baby by 9 minutes and most probably by 12 minutes, all the delivery action should have been completed.
Yeah.
So, this is a novel code 10 for crash cesarean, where the OB-GYN who decides, who sees on the CTG this acute hypoxia, prolonged bradycardia, which is not improving by 6 minutes, will announce code 10 and everybody will be put in action. And the most important thing to remember is that the person who's doing the section is not the person who has detected the emergency. So this is, you have two teams so that you cut short the decision delivery interval. So these are all important things. I don't want to, you can, look at ways and means in different setups. In a single unit, it's very easy from labor room to OT. But if it's a bigger hospital, all these things will take time. So you have to understand how to cut short the time. And crash cesarean section means crash. Within 15 minutes, you have to deliver the baby. Over to you, Surekha.
Yeah. Swati, again, we have a CTG for you to look at and read first, and then we'll give you the profile.
So the baseline heart rate is 140 to 160, good accelerations in the first half. After that, the variability becomes poor in the later half. The contractions I cannot see, but the fetal movements are there.
Fetal movements are there. Okay, the next slide. Yeah, just next. So primary gravida, 30 weeker, IVF pregnancy. Please don't.
Oh, okay.
Please go back. Yeah, that's it. That's it. Okay.
Sorry.
So she is 30 weeks, IVF
and she's a
pregnancy.
severe preeclampsia and she has received magnesium sulfate. So what is
So
now
that's
your
the reason
interpretation?
so that's the reason preterm tachycardia is expected. Poor variability, it can be because of drug induced, which is more commoner with the magnesium sulfate as a neuroprotection they have given. So that's the reason for them.
Yeah. So definitely we wanted to point out that yes, the preterm, now you can go to the next ones, Dr. Mitra. She is on magnesium sulfate. She received steroids. So this kind of pattern where the loss of variability is there and the tachycardia is because she is a preterm and the loss of variability may be attributable to the drugs as well. So this could be a transient type of decrease in variability. And as there are no decelerations, the good movements are there. That indicates that the patient, the baby is still compensated, still well. So that is one sign sign which we can, which is reassuring in this patient. So probably this is a drug effect, and we can wait for this patient for the drug effect to wane off. We could continue the monitoring for the patient, and we have to decide, you have to treat the patient and the disorder, the preeclampsia, accordingly manage the patient, and then maybe we could repeat the CTG for this patient, find out what is the cervical status, and accordingly how the disease progression is there, accordingly we could manage this patient. So let us not treat only the CTG, let us find out what else is there. So acceleration, yes, are absent in this patient. You are right. There are few small accelerations are there, doctor. There are few accelerations, as you can see. There is one here, rightly pointed out by Dr. Mitra. So we need not just worry about the CTG. We have to look at holistically at the patient as well.
So very nicely you have, Surekha, informed that movements are not to be like Dr. Who was answering? Dr. Swati.
Yes, yes.
Yeah, very good. That you have to look at everything. The movements are there. So don't hurry. Stabilize the patient and mature the baby for the lung. Yeah. So Dr. Vijay Lakshmi.
Yes, ma'am. Yeah. Here's the CTG where it is showing my very minimal contractions or no contractions, uterine contractions. And if you see about the fetal heart, there is baseline heart rate is about 150, but there are variability is very poor. There is no accelerations in the initial phase, and then it comes to the decelerations are there, but it's taking a little longer, prolonged time, and then again comes to the baseline of 150 per bit. So it shows that the baby is at distance, but really we don't know what is the cause of it because before variability is there.
So basically, you have picked up very nicely that the heart rate is 150 and the variability is poor. So the clinical profile is that the patient is a primary 36 weeks with tense abdomen, blood pressure is 140 by 100, and it's not a reassuring CTG in the perspective of the risk of the patient, right? So further, how will you manage this case?
Yeah, because this patient is a 36 weeks and the important thing is about BP of 140, 100. So a PAH patient with eclampsia, before we going for eclampsia, we have to do all the investigations and do abdominal examination and see what is the vision score.
That is the clinical examination.
Yeah, clinical
I think this is a
examination.
placental abruption.
Yes.
Because the tense abdomen is there, the clinical examination will tell us about it. And of course, accordingly, we need to manage this patient.
Yeah, once you do a PV examination, there might be a bleeding, which might take us initial to rule out abruption, and we can take care of immediately for an emergency LSCS.
Surekha, we have 5 minutes. Should we take 1 or 2 cases more?
I think we started late, so we can just go through the...
Let's take the case. This one.
Charmila will let us know.
No, we'll take this case, Ranju.
Yeah.
Yes, ma'am.
So please read this CTG, Dr. Ranju.
Yes, ma'am. Here, the contractions are minimal and the baseline heart rate is 130, but there is not adequate variability. It is less than 5 beats per minute. There are no accelerations, no decelerations. It is like almost
like a straight line with no
line.
variability. Yeah. Can we have the profile of the patient?
Yeah. Can I twist the question a little bit? What do you think this is? Is it a baby who's at distress or it could be something else?
Ma'am, likely to be a sleeping baby or a baby in distress.
Yes. Yeah.
Okay. Yeah. Let's have the profile. So she is 39 weeker. Next, So she is a gestational diabetes mellitus, 2 centimeter dilated. Just click on the, and she's come with you with absent fetal movements. Now, what is the interpretation?
Ma'am, even if the baby is sleeping, it must not sleep like this much. Maximum sleep allowed time is 15 minutes. Here it seems to be extending beyond 20 minutes. There is a sleep called deep sleep and an active fetal sleep. Here there is, if the baby is having an active fetal sleep, there must be some kind of acceleration, but it is not there at all. So I would like to stimulate the baby and see
if
there is acceleration.
So stimulation would you like to do VAST? Is important. VAST Secondly, this is a very small snapshot of the CTG. You may want to have a longer trace in this patient. We have to identify. We have to understand she is diabetes. She's having an absent fetal movements as well. So really, we need to take all these into consideration as well. The cervical score here, Bishop score. We need to find out, and we need to plan actually for this patient the delivery. Whatever the delivery, I'm not suggesting that there has to be a C-section, but we need to really plan the termination of this pregnancy for this patient, because the
under close continuous electronic
Yeah.
monitoring.
Sure.
So, okay, I think that should be the last case so that we can summarize. So, who's taking it? Doctor, who would like to take anybody? Lavanya or
No, I think
anybody? Renju.
After Renju, we had Lavanya, is it? Yeah.
Yes,
Swati.
ma'am.
Over to
Okay.
Okay, this is a CTG which is showing very low baseline heart rate.
It's very
So not
interesting
sure,
one, okay?
I'm not sure whether it is fetus or something else. There are no mention about the contractions, and so not much to interpret about the CTG as of now. Probably history and other things might guide us.
Oh, yeah, very good. So you
Very
picked up
interesting,
the
very
thing.
interesting
So here the
comment.
patient came, we given advice for LSS outside, and admission CTG was done by nurse, and all the preparation was done for cesarean section. As you rightly said, Dr. Lavanya, that we have to be careful. So what now do you think it could be?
I think first we should go from history taking whether the patient is perceiving fetal movements, and go for the abdominal examination, see for the uterine height, and see for the fetal heart first by Doppler.
So this was maternal pulse. This was maternal pulse. So always.
Absolutely right on track, Dr. Lavanya. The doctor examined and they couldn't localize any fetal heart. So what is seen here is not actually the fetal heart at all, as rightly
So
pointed
Surekha,
out.
I think I would like to now stop it and you just summarize this thing. Please do this. Surekha, would you like to take this?
I think we have already talked about this, the fetal
Yes.
monitoring checklist, and trying to find out whether this fetus is fit to undertake the progressive hypoxic journey of labor. We really talked about this nomenclature about RUPL, that is relative uteroplacental insufficiency of labor, assessing the intervening baseline, reassuring variability and cycling. These, the nomenclatures have a little bit changed. How we name, how we talk about the CTG nowadays. So these are interesting things which we really need to keep on updating. And at this outset, we really need to assess whether this baby is fit enough to undergo the journey of labor. That's very, very important when you take a CTG. Next slide.
So I would like to just say, imagine a baby who is all alert, ready to make the last call, but, the heart has to be sturdy enough to recover from the temporary hypoxia. So we have to, in our knowledge to understand CTG, it's very important to understand what is the physiological change that's happening to the baby, and whether the baby is compensating, and whether the perfusion of the central organs is maintained or not. So the most important three things are intervening baseline for stability, whether we have a stable segment, because zigzag means that the baby's heart is very, very unstable. Then reassuring variability, everybody has pointed out, and cycling. So a line to say about cycling is it's a normal activity in a mature baby after 32 to 34 weeks. There are three phases: quiet sleep, deep sleep, active sleep, and wakefulness. And these are graphs to explain you. This is the deep sleep where there is very little variability, but we have to, if it will be followed after 15 or 50 minutes by active sleep. In active sleep, there is rapid eye movements. So you're going to get accelerations, and the baby is in maximum time in active sleep. Active wakefulness is not very, most of the time baby is either in deep sleep or active sleep. In active wakefulness, there will be more zigzag pattern, and this is a lesser time, the baby. But what I try to remember is when the baby is in danger, the baby's eyes will open. So maybe to remember active wakefulness is something like that.
Madam,
Whereas in deep
sorry
sleep,
to
the
interrupt,
baby,
madam.
yeah, we're just finishing it.
There's the
The
last
baby
slide.
is quietly sleeping, and in active sleep, which is the maximum time the baby spends, all the accelerations, because well oxygenated baby is going to show all these features. So basically, Chinmay has already mentioned this caution checklist. So
Yeah,
our
so
final
finally,
message is,
yeah,
yes.
finally, final message for all of us to remember is, yes, the CTG is important. It is an assessment tool. It is a monitoring tool. But let us not treat the CTG, only interpret and treat the CTG, but holistically, we have to treat the patient and not the CTG alone. That is our take home from today's. Thank you very much,
Yeah.
Dr. Chinmay. Thank
And
you.
a baby
Yeah.
is a very, very active member in the process of labor, along with the mother and the obstetrician. So we learn to observe the baby's heart, which is responding by a decrease in the rate to decrease its stress. That is what is deceleration. Because for years we've been, cautioned about early and late, and we're very scared. So when we look at deceleration, please do not be afraid. See how the baby is recovering. Thank you, Dr. Charmila. I hope we are in time.
Thank you,
And thank you, our
ICOG.
panelists. They've done wonderful.
Thank you so very much.
Thank you,
It was
Sureka.
wonderful for us also. Thank you.
Yeah.
Thank you.
Thank you, Sureka. Thank you, Dr. Mitra, madam. Wonderful panel. And I hope you appreciated the panelists, all young, but all very, very active in obstetrics and very passionate about obstetrics, which is very rare to see in youngsters now.
We
It
were
is
so
rare to
happy.
find good obstetricians nowadays, especially, when everybody is going into infertility and
fetal
endoscopy.
medicine.
But I'm happy to say, Dr. Charmila and all of us, that our attendance is fantastic. The 3-day labor conference is a box office hit.
Thank you, ma'am.
Yeah.
Kavita, we will go on to the post assessment. So you have to unmute yourself. Shreya, you can put the link. It will be for 10 minutes.
Yes, ma'am. Yes,
Yeah.
ma'am.
There is one observation that false positives are high in CTG interpretation.
Madam, please answer. No, please answer in the chat box.
Okay, I'll do that.
The QR code is not. Acha, okay, now it's there. Yeah. Can see.
Hello.
Till that time, let me tell all of you that we have a wonderful ICOG conference at Pune, 1st and 2nd March. Please block your dates. It's going to be a great academic bonanza.
अच्छा
Rashmi, we need to give answers for all the questions.
Yes.
Before they display the answers, I must appreciate efforts put in by our organizing team, the three conveners, Charmila, Rashmi, and Poonam, and of course the coordinators who are sitting there all through monitoring everything. So thank you, Kavita. Thank you, Monica, who's going to be tomorrow's coordinator. And yesterday's was Umayyal. Very well done. I'm sure the delegates are immensely benefited by all the lectures and the wonderful panel that took place some time ago. So we will be seeing you again tomorrow for the last day of the certificate course on labor and birthing. And I'm sure all the sessions would be useful to you in your clinical practice and making a positive change in your day-to-day OBGYN practice. So thank you. And Rashmi, let's hear the answers.
Thank you very much, sir. So the first question is, labor phases have been defined.
Rashmi, your voice is breaking.
My internet is little, bandwidth is little problematic, madam, today.
Okay, I'll just do it then. I'll just do it. Is it okay?
Yes, please. Go ahead.
Okay. So the first question is, labor phases have been defined by all except it is Monroe is the answer. Friedman, Zhang, and Cohen have defined labor disorders. And what is the accepted duration time of cervical dilatation? It is 9 hours from 4 to 6 centimeters. You can wait for 9 hours. And which is not a common cause of labor dystocia. It is uterine atony. And which intervention is most appropriate for managing shoulder dystocia during labor? It is a McRoberts maneuver. And which of the following statements about the use of oxytocin in labor dystocia is true? Oxytocin can be used to augment labor in case of hypotonic uterine contractions. Which imaging modality is most useful in diagnosing CPD in labor dystocia? It is ultrasound. Which of the following is a contraindication of VBAC? A previous classical uterine incision is a contraindication. Lady attempting VBAC experiences a uterine rupture, and what is the most appropriate immediate action? It's performing an emergency cesarean section. Which of the following factors is associated with a higher success rate of VBAC? A previous vaginal delivery. What is the most common sign associated with uterine rupture? The fetal heart rate abnormality which starts. And what is epidural anesthesia and how does it work? It's a regional form of anesthesia. It involves injection of an anesthetic into the epidural space of the spine to block the nerve signals. What are the potential risks or complications associated with epidurals? It is infection, bleeding, and sometimes nerve damage. And what types of medications are commonly used in epidural anesthesia for labor? And what is the duration of action? How often you should give a top-up? Bupivacaine and fentanyl, and the duration is for 1 to 2 hours when you need a top-up. And what are the different techniques for administering epidural anesthesia? Can be a continuous infusion or an intermittent bolus. How do you handle a accidental dural rupture, or puncture, or other complication? You immediately stop the epidural and provide fluids and pain relief. And which is the ultrasonographic parameter which is commonly used to assess fetal head descent during labor? It is the angle of progression. What is the most accurate ultrasound measurement to determine the degree of head flexion in the maternal pelvis in an occipito anterior or occipital transverse? It is the occipit spine angle. What is the significance of assessing the head symphysis distance using intrapartum ultrasound? It assesses the fetal head descent. What is the degree of posterior cervical angle? That is a predictor of prolongation of labor. It is less than 120 degrees. And what is not true regarding meconium aspiration syndrome? It does not cause persistent pulmonary hypertension in newborn. It causes actually pulmonary hypertension when there's a meconium aspiration syndrome. Thank you so much. And I think Dr. Anupama has joined. People who want to stay back and stay for some time because there was we wanted some clarifications from Anu regarding intrapartum ultrasound. Anupama, you're there? I saw you that you're joined.
Okay, Charmila, I am logging out because I have the organizing committee meeting for the next week's ICOG conference, and I once again take this opportunity to invite you all to Pune. My governing council members will definitely be there, but whosoever can make it, we still have few places available. So please join in and let's make it a very, very useful and interesting event. Thank you, and I'll see you all again tomorrow.
Yeah.
Best wishes for ICOG.
Thank you, Parag, so much for joining us every day. Thank you so much for that. Thank you.
It's my duty. Come on.
I think
you
Parag, you have
encourage-
also been there all the time.
And it's so encouraging, that is. That's what I'm saying. It's always encouraging.
It is our program, but tomorrow I'll be in Kanpur for the Indian Menopause Society conference. So I may not be able to sit all through,
Yeah.
but then I'll definitely try to be there at 4.
Yeah. Thank you so much. Thank you.
Thank you. Bye-bye.
Right. Is Anupama there? I think she joined. Reshmi, can you give her a call? She can do the presentation again. Any other questions are there? You can unmute yourself. Can you unmute everybody, the host? Host, please unmute everybody.
Done, ma'am.
Okay. Anybody who wants to ask questions to the experts who are here, please open your audio and you can talk.
Excuse me, ma'am.
Yes. Please introduce yourself.
Ma'am, I'm Dr. Rinku Rawat from Bhopal.
Yeah,
Ma'am, one of my query for the VBAC, just you have asked one question in the questionnaire, vaginal birth after cesarean section. So what is the most appropriate option? But when we take for the previous normal delivery, so it is very easy. It will not come in the VBAC. It is VBAC is the vaginal birth after cesarean section.
No. She's had one cesarean and one vaginal delivery, or she's had in her series of deliveries at least one vaginal delivery. It makes it easier for her to deliver vaginally again when you give her a trial of labor. That's what it means.
Okay, it means that first she's having vaginal delivery and then cesarean, then
yeah. She would have had a vaginal delivery in between a cesarean, so that actually gives a better outcome. That's what she meant.
Okay. Thank you so much. Thank you.
Thank you. Anything else?
Good evening, ma'am.
Good evening.
I'm Dr. Subhna Prabhakaran from Salem.
Yeah.
What is the time interval between two CTGs, ma'am?
Time interval between two CTGs. Mitra, madam?
See, actually, if it's a high-risk pregnancy, then it has to be continuous electronic fetal monitoring. But if it's a low-risk patient, although it's not recommended, but it would be abundant caution if you do intermittent. So while you are monitoring the progress of labor, also if you can review the condition of the baby. So there is no hard and fast rule. It's already only continuous or intermittent. But I think, our own clinical judgment and understanding the CTGs is very helpful. One thing that if somebody will look at the labor care guide, where the second stage has now been given a lot of time. So 3 hours, if you have to wait, it's not possible for us to just keep waiting. So if we have a CTG monitoring in the second stage, you know that this baby is coping up or not coping up. So basically, if you understand how the graph is coming, what is the recovery of the baby's heart rate, that will be reassuring for you to even wait. Otherwise, that's why we panic, in second stage, we make them to deliver. So I think second stage CTG, it has to be continuous. And in first stage, according to the risk in the mother or the baby.
Kavita is from CMC Ludhiana. Kavita, what is the protocol in your labor room when you have a low-risk mother? How often will you repeat a CTG?
No, for actually low-risk mother, we do not usually use a continuous CTG. Maybe once in a while, intermittent CTG we do use, because it's reassuring not only for the patient but also for the residents
for
who are
us, basically.
But the question is, what is the time duration you will leave if it's a low-risk mother?
Every 20, for 20 minutes, maybe after 2 hours.
Actually, it can be, self-designed. So when we are monitoring the labor of the patient, if we are doing a pelvic examination every 3 hours, it's absolutely fine to repeat a CTG of 15, 20 minutes over after 2 or 3 hours. And if it's good, then actually, if the baby is behaving very nicely and there is no high risk, we can go on to, intermittent auscultation. But intermittent auscultation has to be done religiously. It's not like this that you are not putting her on continuous CTG, so you're not going to monitor. You have to monitor the fetal heart. So that stays there.
Actually, ma'am, will depend upon the stage of labor as well, whether she's
Yeah.
in latent phase, active phase. So,
Once patient is in active labor, you
Yeah.
have to, take a call. Because if you understand how the tachycardia is there, or there is bradycardia, and there is no variability, there is no cycling. Because see, cycling means that the baby is in between able to sleep, and our duration of labor is not less than 8 to 10 hours. So we have to get that segment also. So cycling is a reassuring factor as well.
Madam, I am Dr. Kirti Nahar from Apollo, Ahmedabad. My question is, the previous partograph which we used to follow was much easier to interpret, and we all are comfortable with that. But the newly introduced one by WHO, it is very confusing and it is not very easy to interpret. So, what should be done for this?
Dr. Charmila, will you take this on labor care guide?
Madam, I didn't get it. What was it?
Dr. Kirti has said that initial partogram was easy, the earlier one, and the
Yes,
labor
ma'am.
care guide is very complicated.
Yes, ma'am.
So
It's
what
too
is
complicated.
the midway?
No, that's what Dr. Yashita will be talking tomorrow. We'll bombard her with questions, I thought, because for a practitioner at a private level, and when we don't have those continuous deliveries happening. When we have it like a private practice, we are not used to like putting those labor care guide, which seems so tedious. That's a very relevant question. We'll ask her like how they can ask for some modifications to make it simpler.
Yes,
Okay,
ma'am,
madam.
because things should be made simpler, not complicated.
Yeah, it's too complicated actually.
Yeah.
And
It's too busy. It's too busy actually.
Now only we have trained our paramedical staff on the regular partogram, and now they have changed to so many things. So it's so difficult to teach them.
Actually, from partogram, WHO partogram, we obstetricians of 2 decades earlier also did this paperless CTG, which Dr. Alok Devdas told, that when you do a PV, you in your own mind calculate this is the finding of the cervix, fully phased 4 or 5 centimeters accordingly, and then you extrapolate. So we made it very simple. But actually, if you see, it does follow that timeline. If you have seen that this is the way the contractions are coming, this is the dilatation. So the prediction we as obstetricians over the years, actually, Dr. Charmila, you with and our team of ICOG and FOGSI should have our own data. I mean, we can generate much more, and basically it is a retrospective calculation. So
one of my
writing the whole
residents did a
story,
thesis on
जन्म
this.
पत्री लिख रहे हो आप पूरा लेबर केयर गाइड में, वो tedious हो जाती है, but medical colleges can,
Shobha Gudi
devise
madam
it.
wanted to say something.
Did a thesis on this, on paperless and compared with the conventional partograph. So she found that it was as effective in prediction as the original partograph. Yeah.
Madam, also the alert line and action line, it was much easier to interpret.
Shobha
And
ma'am, you're not heard. Something is wrong with your microphone.
Madam, you have to probably take off something. I think Anu is not joining. Okay, we'll ask her to join tomorrow. Reshmi, she is joining?
No,
You are
I'm not
unmuted. You are unmuted, but we can't hear you. From your side, some audio issue.
No, Rashmi wanted to say something. Rashmi, Anu is joining today? Anupama?
No, ma'am, she's not taking up the phone.
Okay, then it's okay. So you have your questions, we'll ask her to join
I think
tomorrow.
Dr. Chinmay, you should be prepared with use of ultrasound in labor also.
Ultrasound we use.
Yeah, because it is very interesting and very
The
informative.
use of ultrasound in labor, only one thing.
You have a presentation now, Chinmay. Can you show us?
Right now, ma'am. No, right now I don't think I'll have one ready on this. I'm in my hospital right now. This is a different system. But the thing is, the message in ultrasound in labor is it is the third eye of the obstetrician, provided you keep the other 2 eyes open. So you can't go only by the ultrasound method. It has to be I mean, it's just a compliment. And the way it helps is it helps in counseling the patients, because you have seen that this is how it is going. So what we feel is the patients feel more reassured and convinced when you tell them that, the progress is not happening. And we've been monitoring like this. And the other thing is the documentation for instrumental deliveries. Because if it's a failed instrumental delivery.
The thing is, see, we all take classes on ultrasound, but it never enters our head. Still, I rely on my fingers and the way the progress. We are not tuned to the ultrasound. That's why
correct. No, one thing I will say, Charmila, that if somebody has an ultrasound in their setup, that's the best way, because I also never used
Madam,
to use an ultrasound.
I have 2 ultrasound machines, I tell you.
But what I'm saying is that it is
feeling-
really very helpful, because even ICOG says that our clinical examination in determining the position and the flexion and all is far less inferior to ultrasound prediction.
The purpose of me asking that question is I just wanted Chinmay to give us an idea like how we do an ultrasound, because all that angle, all that progression, everything leaves my mind the moment I hear it. I blank out. So give it very simply to us to make us understand.
It requires some training, Charmila. It requires a minimal training. That's all. Nothing. It is not a very it is not very difficult.
Because we are so ultrasound oriented, we find ourselves blind when we go to the labor room without an ultrasound.
Give us the answer now. Give us the answer now, Shobha madam or Chinmay. We want the answer.
I just wanted to comment on the LCG. And then Chinmay.
We want the ultrasound. Tell us in simple terms. I put a probe.
Chinmay, you can
see
put.
if it's LOA, ROA, and suppose
so,
I want to know the descent.
ROA is very straightforward. When
straightforward,
you put on the abdomen, you see the spine. And wherever you see the spine, you know this is LOA or ROA. Then you go down into the suprapubic region, and that is where you make an assessment of where is the pubic symphysis, where is the head. When you're doing a BPD, actually, sometimes even in the 3rd trimester ultrasound, many times we are not able to get a proper BPD. And that is when we tell the patient that, the head is actually engaging, and therefore this cannot be taken. So people who say, I always get BPD, I always get MC, I am doubtful about that. Because after 36, 37 weeks, so many times the head goes down. So when you see the spine, and what that you mentioned, the occipit and the spine angle. So this is exactly what is your, the way you do your Buddha pelvis. When the head is completely flexed, so you will have the angle which is going. So you get an occipitobregmatic angle, occipitofrontal line there, and then you get the line with your spine there. So you are able to see that, progression of the head into the canal. Then you can augment it with transperineal approach. You can use the same probe with a little glove, and you go down and then you assess. So whether the caput is coming down or the skeleton itself is coming down, it's very easy to see then.
The bony margin should descend.
The bony margin will tell you that there is actual descent unless there is molding. And if there is molding, you will see that overriding.
Molding will be seen. Molding will be seen.
Actually, the acute angles imply that it is a deflexed head. The obtuse angles show that it's a well-flexed head. That's what we have to remember, mota moti. And if the eyeballs are looking at the probe, it means it's an occipito-posterior position. It's very simple. Right and left. See the spine. If the spine and this is acute, it means it's a deflexed head between the occiput. So, like what Chinmay has said,
if it is a phase to pubes, it's not always an indication for cesarean. Phase to pubes delivery is very much possible. So please don't consider that.
Mento anterior.
No mento. It is not phase. It is not phase.
Phase has to be.
What I'm saying is acute angle is bad. Obtuse angle is good.
Acute angles
simple
will
message.
Imply it's a deflexed head. Obtuse angle mean that it's a well-flexed head, so the angle between the spine and the head is obtuse. Similarly, angular progression is very simple. You have to look at the pubic symphysis, and in relation to the pubic symphysis, where is your station of the head? Again, that angle, if the head is low down, it will be obtuse. If it's high, it will be small angle. So basically,
acute is bad. That's all.
Yeah, acute is not good. Obtuse is good.
Good. Yeah. Perfect. That's simple.
That is simple rule.
Okay.
And actually, angular progression is very simple. You just extend the length of the pubic symphysis line and the leading point, and where the tangent Meets, that's the angle of progression.
Okay, I got it. So I'm ready for
yeah.
tomorrow now. Okay, I'm leaving.
Yeah.
Thank you so much. I
My
understood.
question is
That is
to
very good.
Dr.
Yeah,
Chinmay.
I'll just comment one fact on the LCG guideline because we have been using it for the past 2.5 to 3 years, Chamila,
Yes,
in
ma'am.
St. Philomena's Hospital, and our one of our students completed a thesis.
Okay,
And I
ma'am.
wanted to share that we did find a statistically significant decrease in the rate of cesarean section in the LCG group compared to the conventional partogram, and it is not difficult. It is not difficult. Please remove the thought from your mind that it is difficult. It only requires more patience. And
So
that
I
yields
think,
in better vaginal birth. It only
so I
requires more
think,
patience. It's not
Dr.
difficult.
Dr. Shobha, I would like to put one thing, that if it's the practice of how you do the obstetrics, it has nothing to do with the labor care guide oblique partogram. That is just way to monitor. So if your practice is of defining the stages of labor, whether it is active labor,
Yeah,
what is
but
the progress,
the purpose
you have to
of
follow the
LCG
same thing.
was to
Okay,
increase the
Cannot be the
timelines in labor.
We'll meet tomorrow.
Yeah,
We'll meet
it
tomorrow.
was to
for a
increase
good-
the timelines in labor. The problem with conventional teaching in obstetrics is that you cannot allow the sun to rise and set on a laboring woman. Now that has to change. That has to
Okay, I
change.
have to leave. I have some
Yeah.
guests. Bye-bye.
So,
Thank you so much, Chinmay.
just as
Thank
an
you so much,
example.
Charmila. Sorry.
Yeah. Yeah, Mitra, that was
Here,
excellent.
Charmila
Excellent
bar
panel by you.
Chinmay. Charmila
Sorry,
bar
sorry.
Chinmay. Oh, no problem.
Actually,
Bye.
Charmila, Chinmay are so. Okay, bye. I
Interchangeable.
enjoyed it thoroughly.
Bye.
I'm so happy. So much of audience.
Yeah.
Lovely. I'll be
So-
there tomorrow. Bye.
So increasing the timelines in labor, more courage as an obstetrician, more patient waiting, and it yields results. It has given results for us. So I think there has to be some passion and more patience, right? Patience, and perseverance. That's like the 3 P's: power, passenger, passenger. There has to be passion, perseverance, and patience in labor room. And LCG guideline is very much possible and implementable. And especially the companion part, we are finding it very useful. We are finding it very, very useful. So I think we need to have maybe a special training for that. Charmila, you can organize at the next level and then you can take it forward. Yeah. Thank you.
Dr. Shobha, I just wanted to ask the thesis whether it was a comparison with the conventional partograph or just the labor care guide. You're muted.
It was an RCT. It was a randomized control trial. And we found that assigning women to low risk gravida, of course, we did not step away from that because LCG has been primarily researched and implemented for low risk gravida. So we also kept the same because this was a thesis setting, no? This was for a postgraduate. So we did not want anything to, maybe going forward, more complex clinical trials can be floated in which you can have high risk gravida as well. But we kept low risk gravida and we found that it yields better result. So it's worth pursuing is what I'm trying to say.
Little cumbersome, tedious, but it's like getting used to something.
No, if the team is oriented, then it becomes very simple. The whole team should have the same orientation of following this. And yeah, even the nurses, the ANMs who come to help, the midwives who come to help, the doctors, residents, consultants, everybody should do the same thing, then it is fine. It's not hard. It only requires patience. It will work best for institutions where there is a handing over protocol.
Yeah,
If suppose,
introduce it actually.
if you have a private, totally private, where the woman expects the only one consultant to come and deliver, it may become a little challenging. But otherwise, if it is a teamwork, an institutional work where all the time there are shifts happening, it is a very, very good intervention for reducing cesarean section rate, intrapartum cesarean sections. Yes.
Thank you.
My last question to Dr. Chinmay. Are you there, madam? Dr. Chinmay, are you there? I just wanted to know that in the CTG we are using newer nomenclatures like quickly and tardy. We are using newer nomenclatures like quickly and tardy. So is it not making things difficult because everybody is following early deceleration, late and variable decelerations? Then why to change all these things, which has been existed for a long time?
Where did she go?
Anybody else can answer?
Can call her, huh? You want to call her, Kavita, that there is a question specifically for her?
Let me try. Dr. Chinmay, right?
Just to answer that, Kirti, we have not changed. We have not changed because I think changing standard definitions without enough evidence, because is it evidence based? The new nomenclature, I am not sure. Maybe I must read it up and see, because so far it has not come to my notice that it is evidence based. So right now we have not changed. We are doing extremely well with whatever is there, whatever is already there. We are doing very well. We don't find any confusion actually.
Okay, if she's not there, we can discuss it tomorrow again.
Yeah, you must discuss it
because
with her.
it is on a large platform, so things should be made very clear.
Very clear, correct. You are very right, Kirti. Yeah, very valid doubts. She's coming, Kavita?
Yeah, I just rang her up. She'll just take 2 minutes to join.
Yeah. Must be a bio break. Poor thing. She has been sitting here for 3-4 hours now. So it is working very well for us. And I had put a comment also in the chat box that high false positive rates are there. And the one thing in labor care guideline is that you must always put in another opinion. So if you're planning on a intrapartum cesarean section, you must kind of confirm that diagnosis with a peer of equal seniority or higher seniority or just lesser seniority with adequate experience. And then you can go ahead, because two people thinking is much better than one person in that heat of the labor, right? Because it really validates your indication. So when that happens, when there is a buddy system or there is another opinion coming in, when that happens, better interpretation of the situation will happen. Better interpretation, or the more objectivity will come into it. And we must try it once. So see, for us, most of us, it is already existing. For example, if Kavita is professor, she may be having an assistant professor or a lecturer doing duty, right? And then that person, having decided, will always ask you whether I can go ahead for cesarean, and you can have an assessment, and then you can say, even though you're not present on the site. So this CTG gets shared actually with the patient details, and then we can always tell them to delay cesarean and not to act on that, and to wait and to bring in some other interventions like more comfort or more hydration, change of posture, and then see if progress is happening, and then allow her to deliver. So one of the aspects of LCG is that you can have a second opinion from a very reliable source who is equally reliable as you are, and that will benefit the woman more. It especially applies to two things. One is interpretation of the surveillance, whatever is happening, and the second thing is the station. Because after all, the whole talk about the intrapartum ultrasound is to improvise in assessment of station of the fetal head and attitude of the fetal head. These two things which have a longest learning curve for an obstetrician. All of us have felt that they have the longest learning curve, and even seniors go wrong in that. So intrapartum ultrasound helps in that, improvises us. It will reduce our errors. So these two things are where the second opinion is needed. One is the station, the other one is surveillance interpretation, especially the CTG. So yeah, Chinmay, good that you are back.
Yeah. So Dr. Kirti, can you repeat the question, please?
Yes, Dr. Chinmay. My question was that we are using newer nomenclatures that you said in CTG, like quickly and tardy. We are more familiar with the previous
Early
ones
and
like
late.
early, late deceleration. So why to change all these things? Because it is always easy to communicate with the older terms, no?
Absolutely. No, it's not like you need to definitely change, but there were certain important observations that they had made in the previous CTG. So what they said was that normal, suspicious, and pathological, that is a very subjective criteria with some unscientific time limits. So here what they have done is, instead of waiting for like 30 minutes and 90 minutes, what they have said is look at the pattern and respond a little faster. So in terms of the definition also, that was 15 beats per minute for 15 seconds. Here the definition they have changed to 30 beats per minute and 30 seconds. And in that zigzag pattern or that variability acceleration, they have even recommended intervening within a month, within a week of, within a minute of any changes in that CTG. So I don't think it is like, should we give up the earlier one or take up the new one? But I think it's a good idea to like investigate, because they have made it a little more robust in the form of, is this fetus okay to take the stress of labor? Because today you will be asked questions about why did you not allow labor and why did you take it up for a cesarean section? So here the answers are very much more numerical. And because you have taken that caution checklist and you have put yes, no, yes, no, yes, no, and therefore you have a more robust method of saying that I cannot allow labor for this particular fetus. If you change anything, you want to change your intrapartum management, then it just gives you another way of it. I don't think what we were doing in the past is wrong or thing. They have suggested, like Shobha madam said, when there is a new thing that comes up, initially it looks very difficult. Every change, we have a sense of resisting that. But in terms of CTG, in terms of Dopplers, in terms of all this IUGR management, if you look at the old concepts and the new concepts, they are not completely 180 degree of each other. But the change is in the way that you put it together. So just like that stage-based management of IUGR, you have the similar things. You have the Doppler changes, you have this thing, whatever the grid trial said, slight changes have come into this, but you continue to do that in a more compact manner. So you can say stage 1, I'll do this. Stage 2, I'll do this. Stage 3, I'll do this. So they have reclassified things. So I felt this was also like this. I also read this article very recently. I read it 2-3 times to understand it. But I mean, it's interesting. So I'm not going to reject it outright, because Chandraharan and all have done so much work on CTG. So if they say something, I think we have to regard it. But honestly, I have not used it in clinical practice. We'll start doing it now, and let's look at it for the next few months. And this is a 2024 publication.
Okay.
Dr.
And,
Chinmaya,
yes.
Dr. Chinmaya, can you share that article in the chat?
Absolutely,
This article that
absolutely,
you
sir.
mentioned.
I
I'm
will
Dr.
just
Chellappan
share
from
it.
Also
Bharuch.
go through it again.
Yeah, it is interesting. I'll just share it. I shared the reference. I'll just share this also. I have the article with me. So can we attach it here? Somebody has to help me.
Or is
Poonam,
it possible to
can
get it
we
from your
attach?
WhatsApp?
Yeah. Oh, I can put it in the WhatsApp of this thing. Is there a method of attaching? There is something file. Yes. No, I am able to wait. I'll do it.
We'll take a picture.
Downloading the article. Yeah. I have put it in the chat. Can you see?
No, actually, it's not visible in the chat.
Okay, it's just loading. Yeah. Got it.
Yeah, now it's come. Yeah.
Got it. Yeah, that is the article. So even the labor care guide, I can put it. I have that also.
Yeah, please.
So we have to download it, no?
I'm just posting it here, ma'am. You just download it directly from here. Yeah. Yeah. Can you download?
Yeah, I could.
Yeah. Thank you, sir.
Yes, doctor. Thank you, Dr. Chinmay.
Thank you, Dr. Chinmay, for rejoining. I think for the third time.
It was a nice presentation. Very nice.
I thank Charmila ma'am for the topic because of that only I was thinking. And Mitra madam actually led to this article. So that is actually the advantage of discussing within us. No, we get so many ideas. Okay, so with your permission, can I just exit? Thank you so much. Thank you, Shobha ma'am. Bye, Kirti ma'am.
I think.
Bye.
Bye,
Bye.
Chalapan sir.
Thank you. Thank you.
Bye, bye. Bye.
Thank you.
May I stop this recording?
Yes, ma'am.
Close the meeting.